got him. Okay.
Alice.
There's a witch nearby.
Yep. Indeed, there is.
Oh, she's literally right under you. Oh,
She is right behind you. I need
Right
help.
I didn't see her.
God damn it,
I genuinely wasn't memeing this time. I didn't see her.
You should have just listened when I said move.
You didn't say who it was. She was right under you, dick. I love that walk stance. That is a very rootin' tootin' I'm going shooting. Oh, fantastic.
Oh, Jesus.
No. Okay, no. I'm looking away.
Right, hello everybody. Got to wait the perpetual second for my camera to load up. With all of my constant computer crashes, I have not my computer crashes. Sorry, my camera crashes. I have to keep the camera switched off when it's not in use, which means when I switch it on, it takes a couple of seconds to remember how to fucking work. But welcome in. I know we can't see anything at the moment. I'm just finishing getting something set up. Alright. So, welcome to something new today. Oh, hang on a minute. Do you own, play, or enjoy Hitman World of Assassination? I couldn't get into World of Assassination. I don't know. There was something about it that just I don't know. I couldn't quite get into it. I really enjoyed the Hitman series, Mono. Of course, I am old enough that I've been playing the Hitman series since Hitman 1. I loved Hitman 1. Hitman 2 was probably one of my favorites of the series. I really enjoyed Hitman Blood Money, but that was when my kind of attendance with the series sort of dropped off. So, yeah, World of Assassinations. I don't own it, but they had a free weekend a few months ago that I tried to play it, and it wasn't a. Don't get me wrong, it wasn't a bad experience, but it just wasn't. It didn't feel very Hitman, you know? It felt a little bit too easy, the fact that you could just, you know, go into like a special view mode and see all the enemy guards, and I don't know. It took a lot of the nuance from what was a Hitman game. Hitman arcade mode. Yeah, that's exactly what it felt like. Hitman was good because it was complicated, it was nuanced, and like Hitman Blood Money, the reason that I loved that was because, you know, things were really unexpected. So for example, if you killed a guard and a civilian ran into the room and then like the civilian couldn't find a way out of that room, they would pick up the gun and try to defend themselves. Like that's a big like nuance, a curveball that like makes you really have to think about who's around you when you take actions, because it's not just the guards that can defend themselves, and you know, you have to properly investigate. You don't just instinctively know where your targets are. Yeah, I think that's basically the thing, Mono. Hitman World of Assassinations did just seem to take most of the nuance out of the series, which is probably why I couldn't get into it, because I am known for, you know, some more of the complicated titles. I don't know why the chat isn't showing up in that little box. But yeah, speaking of complicated, we are going to be doing something new today. So what we are going to be playing, let me see if I can. Alright, let's see if this works. Oh, it does work. Perfect. Okay. So we are going to be doing some full code medical simulation. Now this was a pretty unexpected twist, because I was I was sitting there last night trying to work out desperately what I wanted to do on stream today. And nothing was really taking my fancy. But then I stumbled across this, which is, yeah, it's basically like a full medical simulator. Now, for those of you who have been with my streams since I started, you'll know that one of the first series that I did regularly was Project Hospital, where you could build up a hospital, and indeed Doctor Mode added the ability to actually take on the cases yourself, which was really enjoyable. And a lot of the feedback was that, you know, people quite enjoyed when I did that. That was where the whole Hibbles Health Advice, the name of the stream, comes from. Similarly, after that, we went on to do Resuscitation Inc., which was an ambulance simulator. And I still maintain probably one of the best ambulance simulators I have seen. And then, you know, more recently than that, we have had Ambulance Life, a paramedic simulator. So, you know, we've done this quite a lot. It's an area of, you know, it's an area that I'm knowledgeable about to a certain point. I'll get into that in a second. But I also really enjoy partaking in and you know, trying to explain. With that in mind, here is the important disclaimers, because I wish I didn't have to do disclaimers, but this is the internet, and there are people on the internet who are fucking dumb. So what we are about to see is, this is a medical simulator. This is not strictly a game. It is accessible to everyone, regardless of whether or not you are a medical professional or not. This is going to deal with medical procedures and medical conversations that some people may find disturbing or uncomfortable, so bear that in mind. Please remember, this stream is for entertainment purposes only. It is not a reflection on my clinical skills, and anything that is discussed is not medical advice, despite the name of the stream. The name of the stream is just a meme, but yes, everything that is discussed in here is not medical advice. If you have any health concerns of your own, you must speak to, you know, your own doctor or appropriate healthcare provider. The other thing to bear in mind is that this is a doctor level medical simulation, which is significantly higher than my degree of medical training. So as we explore this, I am probably going to get things wrong. I'm probably not going to understand things. So yeah, just remember that not everything you are going to hear in this is going to be absolutely gospel. The final thing is, this does use the American healthcare system, which is different from my healthcare system, so some things may be different or wrong depending on your local area. We are not getting sued for malpractice, Mono, don't worry about it. Oh, we do have the chat. Okay, we do have the chat box open. Yeah, okay. The chat box can work. I figure we'll do the chat box for this one. Yeah, we are not getting sued we're not getting sued for malpractice. Okay, so what we'll do is we'll do the weekly challenge, and we'll kind of take it from here. So yeah, without further ado, let's kind of get into this. So, we have a 31-year-old female with right-sided abdominal pelvic pain for the past 2 days. Patient reports subjective fever and chills, and last had a period 3 weeks ago. Okay. Alright, well, let's hop into this. So this, I have done one of these as a trial to make sure this is all going to work. I did do it on the mobile. It's lupus. I did do it on mobile. So this is my first time trying it out on the computer. So yeah, let's see how we go. So the patient is a walk-in, and the triage nurse reports basically what we have just read out. So it is time for us to assess the patient. She is clearly grimacing in pain. So in this case codes AI patient dialogue. This works really quite well. So I'm quite you know, I'm quite looking forward to, you know, actually using this. So the patient appears uncomfortable. We can see that, and is GCS 15. For those of you not in the know, GCS stands for the Glasgow Coma Scale, and is a way of assessing how conscious and responsive somebody is. So GCS 15 is the highest score that you can get to. So this is all pretty good. What we're going to do is we are going to start by checking some observations. Okay. So looking at this, we are we've basically got a low-grade fever with a temperature of 38. Oxygen saturations are good. Respirate is high end of normal, but still normal. Our pulse is tachy, and our blood pressure is normal. So this is the signs of somebody whose body is struggling, but not catastrophically so. This isn't a critically unwell patient, so for this we're not going to jump to rapid assessment, rapid treatment. We're going to, you know, we're happy we can slow things down and take this as it comes. So thank you for seeing me. So apparently there is a dictation function, but I'm not sure. I'm not actually sure how to access it. Okay, so thank you for seeing me. So I'm gonna say I understand. I understand you have pain. Can you tell me more about where it is? So it's pain down low on the right side of the pelvis. So not even abdomen. It's below that. So yeah, it's quite far down. So one of the tools that I'm going to use just now is a tool called Socrates, which is a way of assessing pain in a quick but consistent way. So it's abbreviation. So S stands for sight. O is onset. Okay, when did this pain start? So we think about 2 days. Started about 2 to 3 days ago. Another thing that's relevant in this question is what were you doing when... Can you make guesses? Yeah, you can absolutely make guesses in the chat. What were you doing when the pain started? Were you moving or at rest? So the next letter is O, which is, yeah, onset. So we've asked about what time it is, and also what were we doing when it started. You weren't really doing anything special, it just started hurting. Okay, I'm going to assume that means that we're at rest. Our next thing is character. So what kind of pain is it? So what we're looking here, is it like a throbbing pain? Is it a sharp pain? It's a constant aching pain, like a 10 out of 10. So that answers our final question, which is severity. So Sock R, R is radiating. So does the pain radiate anywhere else? Kidney stones is a good shout. Kidney stones is a good shout. Yeah. On the right side, my first thought, lower right side, is maybe appendicitis. That's what I'm thinking at the moment. But also it's pelvic, and we are female, so we also need to consider about the kind of the reproductive tract too. So there might be some things in there. No, it just stays in that spot. Okay. So do you have any other symptoms with the pain? So after radiation is basically A, which is your associated symptoms. So we've been a little feverish, so hot, cold, so fever, and we do know that we have a fever, so that kind of ties in with this. Fine. T is timing, so we're going to ask, is the pain, or does it come and go? Constant. We did actually already answer that earlier, but yeah. So it's a constant pain. We next move on to the what is effectively going to be the last letter, which is E. There is an S after it, but we've already answered this, the S, which is severity. So the E is exacerbation. So is there anything that makes the pain better or worse? So it doesn't get any better with position changes. Okay, so we're going to probe that a little bit more. Is the pain worse when taking a deep breath in? Okay. So if the pain is worse when you take a deep breath in, it can imply a kind of issue with like the respiratory tract. That might be the source of where the infection is. Also, you know, because when you breathe, your diaphragm moves around quite a lot. It can kind of, you know, it can also make abdominal related conditions feel a bit worse as well. Okay, and does the pain get worse when you press the area? So is it tender? Yes, it hurts more when you press on it, which is a bit of a misnomer. This is one thing, you know, if you say you've got 10 out of 10 pain, 10 out of 10 pain is the worst pain you could possibly have. If it has the ability to get worse when you press it, then it's not a 10 out of 10 pain. Do we know if the patient has their organs mirrored? What, situs inversus? That's a rare one, Mono. Okay, so it is tender when we press on it. Okay, fine. Okay, so our next step is, can we give you something for the pain? Yeah, that would be nice. Okay, right, fine. We've done our Socrates at the moment. So we're going to... So Socrates is very specific to pain. We're going to move on to what's called sample. Now, we already have an idea of the symptoms. So A, we're going to go for allergies. Do you have any allergies? So before we give medicines, we need to know if the patient has any allergies to any medicines, because we don't want to kill our patient. You know, that would be no bueno. No, we don't have any allergies. Do you take any regular medications? You take a pill for the mood and one pill for herpes sometimes. Okay. Now there's different kinds of herpes. There is genital herpes, there's oral herpes, possibly others, I'm not that clued up about it. But if it, you know, genital herpes, this could explain a little more about the, you know, any issues that we have with the genital tract. Okay. So, let's see, for past medical history. Oh, hang on, no, actually, one more question about the medicines. Have you taken anything for the pain already? I love how interactive this is. I know it's AI generated. Okay, we've not done anything for that. That's fine. I know it's AI, but it's quite well done. This feels pretty realistic. I have to be honest with you. No, we haven't taken anything for the pain yet. That's fine. So what we're gonna do then is what is your past medical history? And we've got one more question. Depression, anxiety, and PTSD. Have you ever had a pain like this before? Okay. So we've got some mental health conditions, but no physical health conditions, and we've never had an episode like this before. I think before we do anything else, we are going to go into interventions, and we are going to give analgesia. So for us in the UK, acetaminophen is effectively paracetamol. We will give this. So we'll give some paracetamol and see how we go. And we are going to continue. So our differential at the moment. So let's see. So if we look at genitourinary, if we say, yeah, okay. So kidney stones are definitely one. I've got low suspicions about kidney stones at the moment, but this is definitely one differential. Under gastrointestinal, I'm going to put down appendicitis as a differential. And then in terms of what we're dealing with here, let's go to obs and gynae. So I think ectopic pregnancy is something we can't rule out at the moment. Ovarian torsion, twisted and cuts off blood supply. Okay, that definitely seems like one it could be. Endometriosis is another one that came to my mind. Yeah, okay, so we've got 5 differential diagnoses at the moment. Let's see if we can't rule that one down. We don't really need anything here. So what we'll do, I don't have any airway concerns. We'll do breathing. Yeah, okay, because that's a visual thing. So this is fine. Pulmonary exam. Okay, abdominal exam is the one that we want to do. So perform an abdominal exam. So we've got right lower quadrant tenderness with mild guarding with no rebound, but the abdomen is soft with normal active bowel sounds. So this means we're not looking at like a blockage of the colon at all, but we are definitely kind of in pain. Let's have a little look at the genitourinary. Moderate white vaginal discharge with cervical motion tenderness and tenderness in the right adnexa. No bleeding. Fine. So this, I think, is going to I think this is going to possibly suggest. Oh, I don't know about that one, Mono. I do not know about that one. So I think this finding here is going to suggest that we are probably looking at something in the within the reproductive or urinary systems. But nevertheless, we'll do a back and flank exam, because one thing you can do for like kidney infections and things is like a percussion of the back, and if they fucking cry out with the percussion, there's a good chance that they have got some kind of infection in their kidney. No tenderness of the thoracic or lumbar spine. Fine. Let's just do this one. So there's no cyanosis or edema, that's fine. Warm, dry, no rashes, fine. I've got no indication for a neuro or psychological exam at this time. Let's check in with the patient and see how the acetaminophen is helping. How is the pain now? It's better now, but still hurts. Do you want more pain relief? Yes, that would be good. Okay. This would be morphine. This would be morphine and would involve putting a needle in your arm. Morphine can make you nauseous. Is this okay? Okay, so she's happy with morphine. We've explained. Is the passing of time relative? Does it take effect instantly? I don't know about that one. I don't know about that, Mono. We'll keep an eye on that and see. She is okay with getting IV. So let's go to the stabilize section and insert an IV. I don't know why it's in stabilize, but there. So we've now got an IV in our arm, which is going to allow us to do a morphine bolus, which is now completed. So we're probably going to see this take effect over time. She does look like she's grimacing a lot less, which is quite good. Okay, fine. So I've got low suspicion for kidney stones. Okay. Bedside tests. Okay, let's have a little look. So let's queue up some blood tests. So we'll do an ABG, a chemistry. I want a CBC and a lactate. Oh, urinalysis is going to be good as well. Okay, so we're going to do some blood tests, and then we are going to do some urine tests as well. So let's see what we're working with. Okay, so all of the things are back. So we'll start at the bottom. So the blood gas shows normal, normal oxygenation, normal carbon dioxide, and normal acidity. Well, high end of normal, actually. But still normal, that's all fine. Blood glucose is fine, creatine, fine. Bicarb is up. Sorry, bicarb is down, which is a bit of a problem. And white blood cells are up significantly. So when your white blood cell count shoots up like this, this is a good sign that you are fighting off infection or inflammation. The lactate is normal, which means we're not seeing tissue breakdown as a result of this inflammation. So this is a picture of somebody who does have infection, possibly inflammation, possibly infection, but again, they are not critically unwell. Yeah, could be pregnancy, although you would be unlikely to have this much pain this early on, which is why I've put down ectopic pregnancy as one of the differentials, because that would cause pain, like this amount of pain this early on. In terms of the urinalysis, everything is fine for that one, so that's all fine. Let's look at our other lab work. So let's get a CRP, a cervical swab. Yeah, we'll get some cervical swabs, lactates. Trying to see if there's anything else. So I've got no sign. So I'm not going to do any further here. I don't think I'm going to remove the. I'm going to remove this for now. Okay, let's perform these tests and see what we're working with. So the CRP is raised, which is a very big indicator of okay, all right. Okay, so we do have genital infection. Right. So we've got gonococcal infection. And we have gram-negative diplococci present on the cervical swab. So we definitely have some reproductive things going on. Let's see, let's get as well, let's do an ultrasound of the pelvis and see what it is that we're working with here. You typed that when you were selecting the blood test, yeah. So, I do not know how to interpret ultrasounds. That is way beyond my scope. But the interpretation is that there is a fluid-filled structure at the junction of the right ovary and the adnexa, measuring 5 by 3 by 4 centimeters. Differential would include an ovarian cyst versus turbo-ovarian abscess. Suggests clinical correction. Okay. Fine. So I think what we're looking at here is the picture of somebody who has some kind of right, hang on, how do I do this again? So let's go to this. So what did we say? We said turbo ovarian abscess is an option and ovarian cysts. And a turbo ovarian abscess. Okay, most commonly occurs due to the progression of untreated genital infections, often sexually transmitted infections. So I think the TOA is probably our most likely culprit here. Because we know that we definitely have this. Is there any other things that we can do? So, I don't care about sugars, I don't care about ECG. In theory, I could because our heart rate is tacky, but I don't think our presentation is, you know, we've got a confirmed infection, and our numbers are in keeping with an infection. So let's this isn't cardiac, so I'm quite happy with that one. Could do CT. So I don't know what the difference between. I don't know what the difference between these two is. Let's try this. Yeah, okay, it's okay, it's literally the same. It is literally the same. Okay, let's go for okay, hang on. Let's see what we're dealing with here. How is the pain now? Okay, our pain is much better, and we haven't responded negatively to the morphine, which is quite good. So I think what we're going to do now is we are going to communicate with the Obs and Gynae team and see what their suggestion is. The presentation is consistent with PID and probably turbo ovarian abscess. You'll take the patient to the OR for investigation and possible drainage. Make sure to assess pre-ops labs and start antibiotics. We will consent her shortly. Okay. Fine. What the fuck is PID? I'm gonna have to Google that one. PID. Oh, pelvic inflammatory disease. Bacterial infection of the female reproductive system. Right, okay. Fine. So, yeah. So, we'll put that one in. I think we can remove this one. So, we've basically got two things in play at the moment. I'll take the patient to the OR for investigation and possible drainage. Okay, so let's tell the patient what's happening first of all. It appears you have a cyst. In your reproductive system that will require surgical investigation. Sir, I misspelled that one. The specialist will be down soon to speak to you. Let's see what this does. What does this mean for you? We will get you started on how do I spell whether? Whether you need surgical procedures. Can I start you on anti? Yeah, that sounds good. Okay, fine. Alright, so what we're gonna do then, let's have a look at antibiotics. Oh god, okay. This is where I am unfortunately reminded that I am not a fucking doctor. Pharyngitis. Okay. Fine. We don't have a fungal infection, so that's okay. Ampicillin. Yeah. Okay. Azithromycin. Okay. Azithromycin might be the one that we go for. Fourth generation antibiotic. Hospital acquired pneumonia. Google it? Yeah, well. Cefotaxime. Pneumonia, gonorrhea. Diverticulitis. Doxycycline. Fucking hell. Yeah, this is honestly where I remember that I am not a doctor. And certain genital infections, okay. Metronidazole. Ah, okay. Metronidazole. Yeah, okay, we're good. Metronidazole. Okay, let's get started with metronidazole. Just now. And then we need to get lab work. So I don't actually know what blood works you do pre-surgery. I'm trying to remember what I used to order. Because I used to be a surgical coordinator, but I was non-clinical, so I didn't order blood tests, although I very occasionally was involved in it. I think a coagulation panel is one. A blood screen and type is definitely one. D-dimer, I don't care about. Lipase? What's a lipase? Okay. No. We don't need that one. Liver function's fine. Phosphates. Yeah, okay, I think I'm happy with that one. So we are O positive, and our numbers are all okay for the coagulation panel. So I think it's time for us to hand off this. Oh, jeez, okay. So I think we're going to go for here. So OBS. It will take the patient to the OR for investigation and possible drainage. Okay, so we're going to hand off the patient to the operating room under the OBS and Gynae service. Deep breath. Let's see if this is the right thing to do. Are you sure? Finish. Oh, it does give us a score. Okay, we only got 62% for the investigation. So the ABG was unnecessary. So in my line of work, which is emergency care, everybody gets an ABG. Everybody gets an ABG. Okay, we did that one quite well. The answers we could have done a pregnancy status. Yeah, okay, that would have been quite good. You need to do a pregnancy test to rule out an ectopic pregnancy. Okay, that's my bad. I did serum HHG and a urine HCG. Okay, fine. I thought that was covered in the urine tests, so fine. I wouldn't have really cared about the liver function test, really. Okay, to be fair, I did this one. I think I actually did pretty good in this one. Yeah, I thought the urine test was that I did covered pregnancy, but evidently not. So that's my bad. But yeah, okay, that one's we did pretty good in that one, all things considered. How was the patient AI on this case? Oh, it was, yeah, the patient AI was perfect. It was absolutely perfect. Really enjoyed that one. Okay, that was really good, actually. GG, yep, that was really good. Okay, let's see what we can do with this one. Ah, okay. Oh, this one's fun. So these are all the ones that are actually. Hang on, how? All right. Okay. I think. Hang on. I think I'm gonna go for a random case. I'm just gonna turn this off so you can't see my my details. Hmm. Yeah, okay. Give me a second to purchase this one, folks, and then we'll go do a random case after this one. I don't want you to see my my payment details, because God forbid, I've doxed myself on stream before, and I do not want to do it again. Yeah, somebody told me to buy some CS:GO cases on stream. And I forgot that it was on window view at the time, so whoopsie. Oh really? Which VOD was that? Oh, don't worry, Mono. It was years ago now. That's why I can talk about it, because I mean, I deleted the VOD anyway. I wasn't that fucking dumb. Okay. Yes, let's save that one. Oh, okay. Hang on, it won't. Ah. Alright, give me 1 second to do this, and we'll be back. That is one way to celebrate getting to 100. Jesus! Fuck! God damn it!
Boo-hoo. That's prison fellow.
Yeah, that's pretty good.
Deploy. Fucking deploy! Okay, we're now in the outer fringes of this tornado. We've deployed the probe, so let's yeet. Oh.
There we go, I gotta get the pieces out of it.
Lexi, we're in space!
Oh no! Oh my god! Oh my... No!
I think the physics janked out there.
We're like tossed like a skipping stone.
If you can hear me, are you able to set up for us?
Oh goodness. Billy, is that you?
You need to help us. I can't!
Where am I? Putting the right choice on you, but she's probably doing it with the right intention.
Wait, what the fuck? What the fuck is happening in the distance?
Well, you can train a character to behave. If there's a dog that's not behaving right, everyone.
You know, for a ball guy, you should like splitting hairs.
I mean, I'm not bald, that's a head. Alright, whatever.
Alright, we are back. We are back. Wait, where'd the game go? Huh, there we go. Yeah, okay. We are we're back, and we have done our subscription, so we are yeah. So we can't you know, can't do that one again, but there will be a Monday patient soon. So what we'll do is we'll do a random case. So this should be quite fun. Basic or pro? Oh, no comment. Okay, so this patient is a walk-in. This is a 54-year-old female with right flank pain, and nausea, no hematuria, so that's blood in the urine, and no history of kidney stones. Looks uncomfortable. Okay, let's go ahead and deal with this one. Oh, there's an attending physician. Okay, so we're just in the oh shit, I can look around the room. Wash your hands, kids. This is cool. This is actually quite cool. I really like the interface. Okay. Yeah, that's fine. So let's go ahead and get our numbers on straight away. Fine, so let's look at our picture. So we have somebody who is not side-nosed and can talk, so there's no airway concerns. Their respiratory rate is 18, which is fine. Their oxygen saturations are 99, which is fine. Temperature is fine. Heart rate is fine. And blood pressure is mildly elevated, but not significantly so. Okay. Alright, let's go for it. What can we help you with? What can we help with today? That means I got pro, but don't judge me. Yes, I got the pro one. I'm really enjoying this, actually. I can see myself doing this when I'm not there. When I'm not streaming it, necessarily. Of course, I wouldn't be doing it if I'm not there. You've been having really bad pain in your right side for the last couple of days. All down your right side or in a specific place? It's mostly in your right flank, but also feeling some discomfort in right upper belly. Okay. This could... okay, alright. This could be... Ooh. There's quite a few things this could be, actually. So, off the bat, I am thinking about possibility of... cholectitis. Gallbladder, which is a problem I currently have. Bile duct is definitely one. And then this one is gallstones in the bile duct. So this one is yeah. Gallstones in the gallbladder, and then this one is gallstones in the bile duct. Also thinking in my head of oh, I don't actually think there is anything here for it. Okay. Yeah, I'm also thinking of conditions to do with the liver as well, because that's going to be in that same area, but it's definitely too early to tell. Okay, fine. So when did the pain start? Pain starts. Typing is hard. Pain started 2 days ago. Okay. What were you doing at the time? At rest. At rest or moving. He wasn't doing anything special. Okay, so we weren't at rest, but we weren't doing anything really strenuous. So that's okay. What does the pain feel like? Is it a sharp pain, stabbing pain? It's a sharp pain. There's also a burning sensation. So I'm really thinking about the gallbladder kind of area. Yeah, okay. I've got very, very high suspicion for that now. It feels like a sharp pain. Oh, kidney involvement is still a possibility. Okay, there's also this burning sensation. Feels like a sharp pain. There's also this burning sensation. Do you have any other symptoms? Okay, so nausea but no vomiting. Okay. Oh, I missed one. Does the pain radiate anywhere else? And sometimes goes up to your belly, okay? That's fine. Is the pain constant? or does it come and go? The pain comes and goes in waves. Does it completely resolve? It just lessens, it never goes away completely. Okay, that's fine. Fine, so that's our timing. How long do the waves of pain last? Is it a few minutes? Is it a few hours? It lasts for a while, but can't. So I'm definitely thinking stones, because this is sounding remarkably familiar to my health. And they last for a little while, but I can't exactly say how long. Okay. Okay, fine. Does anything make the pain worse or better? So I'm not really sure what helps or make it worse. Okay. Does the pain get worse if you press the area? Okay. So yes, it does. Does the pain get worse if you take a deep breath in? Let's see. Okay. So remember what I said earlier. You know, when you think of your diaphragm, so your diaphragm is the muscle that kind of acts as a physical barrier between your abdominal cavity and your kind of thoracic cavity. You know, there's organs on both sides of it. When you breathe, your diaphragm moves quite considerably. You know, respiratory infections are a very common one that will hurt more when you take a deep breath in, but also with the movement of that diaphragm, anything that's infected or inflamed in the kind of upper abdominal area can also be kind of worsened by taking that deep breath in as well. So this is definitely pointing to something that is upper respiratory. I'm gonna ask a very specific question here. I'm gonna see how this one does. Does the nausea get worse when you lie flat? Yes. Okay. Right. This is almost to a T my symptoms of my gallstones. Almost to a T, this is my symptoms of yeah. That's funny. That is hilarious. Okay, fine. Right, fine. On a scale of 0 to... What is the pain just now? It's about a 7 out of 10. Have you taken anything for the pain? I love this AI interface. This AI interface feels so accurate. We haven't taken anything for the pain yet. Do you have any medicine allergies? Do not collect 200 Vicodin. So we're allergic to penicillin. Okay, we'll need to keep that one in mind. We're allergic to penicillin and give you a rash. Okay, fine. So do you have any health conditions? Seasonal allergies. Do you take any regular medications? Fine. Okay. Do you want something for the pain? So the reason why I asked this sounds obvious, but remember consent is important for medicine. You should ideally be getting consent for everything that you want to do. You know, your patient should always be informed about what you are doing and I like, you know, if time allows, why you're doing it. Yes, we did. So pain is a 7 out of 10, Mono. I think it's yeah, it's yeah, right where my fingers are. Yeah, consent is important. So it might seem obvious to somebody else that you know, the person is in a lot of pain and would like painkillers. But the truth be told, you should always get explicit consent. Some people, you know, you will find, particularly men, but like people who are kind of age 40 to 60 in general, sometimes like to be really stoic and hate accepting medications. So always get consent. Never assume that somebody will, you know, consent to this. But she's given us consent, so let's start her off with some acetaminophen, which we would know as paracetamol. So we are going to give that one. So we've done our Socrates, we've done our sample. Let's start moving on to our patient is improved. This is fine. So let's start moving on to this one. So airway I don't care about, breathing I don't care about. So well, I suppose these are the fine. So these are the ones that we can do without actually like sitting there and wasting time doing a lot of things. So I don't care about a head exam, I don't care about a neck exam, I don't care about a cardio exam. The pain, do you know what, the pain is worse when we take a deep breath in. So I think this isn't a waste of time to do a pulmonary exam. So clear auscultation bilaterally, no retractions, no wheezes, no rhonchi or rales, so that is fine. Now here's the big one. Let's do an abdominal exam. So we are soft, we are non-tender, we are non-distended, we have normal active bowel sounds, no percussion tenderness, no rebound or guarding. Okay, that's quite interesting. I wonder if there's some way that we can do... can we do a Murphy's test? No. So one of the things that you can do for somebody who has gallstones is what's called, you can look for Murphy's sign. So a Murphy's sign is effectively when you lie flat with your knees up or your knees kind of like, you know, bent in towards your chest. If you push right underneath the rib cage, it becomes excruciating. The text is too small, you're watching on a TV. I mean, I can try and zoom in if you would, if you know, I can try and jury rig something that would work if you want to see it a bit bigger, but it's a bit hard to kind of, you know, yeah, text is always an issue. Okay, fine. Let's have a little check of the gentle urinary exam. Again, we can't rule out kidney involvement at the moment. So let's go for this one. No discharge, that's fine. Hyperthesia of the right flank without CVA tenderness. What the fuck is... Hang on a minute. There's two words here I don't understand. Oh, okay. CVA tenderness is the Oh no. Okay, fine. So CVA is what's called the Murphy's punch, which is basically what I was talking about before for the percussion that you do on somebody's back to assess if you have a kidney infection. If you have a kidney infection, the Murphy's punch is fucking excruciating. Hyperthesia. I think I know what this one means. But I just want to make sure I've got the exact definition of it. Yeah, so thesia is generally like sensation. So when you talk about anesthesia, you are reducing the sensation. Hyperesthesia is too much sensation. So the abnormal increases sensitivity. So fine. So we're quite tender, basically. It's a complicated way of saying that one. Musculoskeletal exam, I think, will be fine. Oh, hello. Vestibular lesions on a slightly erythematous base without crusting. Lesions are present on the right thoracic region and the right lateral chest wall. Ooh, okay. Well, this is just taking a bit of a U-turn. I was so sure this was gallstones, but now I'm not sure. This could still be an incidental finding, but actually I am not sure. Let's check in with the patient. How is the pain now? Maybe a 5 out of 10. Okie doke. We can give you something stronger for the pain, if you'd like. Is it like the fetal position? Yes. Yeah, kind of. Yeah. Yeah, something stronger would help a lot. Okay. This would be morphine. And would involve putting a needle. Morphine can... Okay, so we're explaining what's involved with the morphine. You understand, but you really need something for the pain. We can deal with that later. That's fine. Okay, so in this regard, we are going to insert an IV into the arm, which is now done. And we are going to give a morphine bolus. Oh, we've got more medicines. Okay, we're gonna give a morphine bolus for the pain, and we'll see what that one does. Okay, this is hopefully going to improve the patient's pain score. We can see the resp rates come down, which is something that can happen when you're on morphine. Okay, let's have soft tissue. Yeah, okay, I think... Fine. I think I want renal and an upper quadrant ultrasound. Let's see what they look like. So ultrasound, the gallbladder wall is normal, no gallstones, negative Murphy sign. There is no hydronephrosis bilaterally. Okay, fine. So it's not gallstones. It's not gallstones. This kind of fucks me up a little bit. Okay, let's go for some lab work then. So let's go for... Okay, I don't care about an ABG. Basic chemistry. I think a basic chemistry is fine. CBC is going to be quite good. Lactate's going to be quite good. Can't rule out liver yet. So let's go for let's go for urinalysis, and let's go for LFTs and see what we are working with here. Can you do cultures from the skin pustules? Yes, I think so. I think we can. Okay, so there is nothing abnormal in the blood work. So this isn't a systemic infection that we are working with here. Let's go to imaging and let's grab a CT abdomen. And we'll do this one quickly. So CB abdomen is fine. There is nothing abnormal in that one. Let's check our other lab works. So, pancreatitis. Okay, we are going to go for an amylase, because that is going to tell us... can we do a gamma GTs, I wonder? I'm still worried that we might be dealing with some kind of infection, so... But I think this is more likely to be a skin infection. Lactic acidosis, okay. Okay, I can't see if any way of sampling this. So yeah, this Testicular lesions on a slightly without crusting. Okay. Let's do these tests and see if they have anything. So cultures are in progress. So yeah, we've got nothing abnormal in our blood work. The plot thickens. Plot fucking thickens. Okay, I'm happy it's not any of these. Infectious diseases are definitely an option. Dermatological. Oh. Okay, I don't think it's endocrine. I don't understand what kind of topical skin infection is going to cause this many symptoms. Not to say that it can't, but these are some pretty severe symptoms. Stephen-Johnson syndrome. No, we don't have necrosis of this one. Toxin producing. I don't think it's necrotizing fasciitis. Okay, I think cellulitis is definitely one. Eczematous skin. Let's see. I don't think it's contact dermatitis. Do you know what? Let's speak to dermatology. Let's see what the dermatologist has to say. It seems like the patient might benefit from a course of antiviral therapy. Okay. Let's speak to the attending then. How can we help? Can we get some help with the diagnosis? So review the differentials. So cellulitis, okay. So nephrolitis are kidney stones, crystallization of substances within the urine. Yeah, okay, fine. So that's kidney stones. Acute gastroenteritis. Fine. Cholectasis, lumbar strain, pneumothorax, herpes zoster. Actually, I didn't think about that one. The shingles is caused by reactivation of the chickenpox virus. It causes a vesicular rash. Hang on a minute, I need to Google what this looks like. Herpes zoster. Watch it come up with the first image that it's been. Yeah, okay, it's basically that one. Fine. Okay, but let's do this properly. So we've done the abdominal CT scan, which show. Oh, and we also did the kidney thing, which showed no kidney stones. We've got no gallbladder stones. The bone work in this one is fine. Pneumothorax. There's not a pneumothorax. Abdominal pain, NOS. Can't rule out abdominal pain, NOS. Given it is tender. Okay. So let's go for interventions. Okay. Is this a viral? Yeah, okay, fine. So I think it's going to be antivirals. But we can deal with that one later. I think you have a skin infection. Can we give you some antivirals? Okay, well. Okay, so basically this is a case of like a patient lack of understanding. So she doesn't think she needs antivirals, she's just focused on the pain. Okay, so what we're going to explain is that antivirals will reduce the inflammation which will I've spoken to a specialist and we think it will help. Okay, fine. There we go. It took us a while to get there, but we are there. So what we need is oh fuck. I think it's gonna be okay, haloperidol, miscellaneous. What is an name me an antiviral medication. Let's see. So apparently acyclovir is one. That's down as antibiotics, isn't it? Oh, and yeah, okay, so antibiotics is for antivirals as well. Okay, fine. So herpes zoster, which I think is the one we've got. What was our other differential? Cellulitis, soft tissue beneath the skin. Okay, I think we go for acyclovir. Fine. Okay, let's speak with dermatology. Oh, we can't speak to them again. Is your drink pink? My drink is pink, yes. It's a kind of pale rosé color. Fine. Hand off. Admit to the floor for a dermatology consult. I don't think we need to keep you in... I don't think we need to keep her in hospital, because this course of antivirals is going to take a few days. We are on top of the pain for now. The obs that we are painting here is not the picture of somebody who is critically unwell, who needs to be kept in hospital. I think because of the morphine, we'll probably need to admit to ED observation until the morphine's worn off. But I don't think they need... I think this... Do you know what? Okay. Okay, I think we're gonna go with this one. If I was a clinician, if I was like a real hospital clinician, I would keep them in hospital with for a couple of hours to make sure the morphine had worn off without complication, and then send them home. But I think it's gonna penalize me if I don't do this one. So Let's hand off here. Oh, okay. Okay. Yeah, not much to do here. Yeah, that one was fine. We lost 20% for our investigations. I'm curious as to why. Okay, because of the lactate. CT abdomen was on there. Okay, we did a lot of unnecessary things, but in our defense, those unnecessary things did really help us to rule out quite a lot of the differential diagnosis. This one didn't require testing. Yeah, that's fair. I don't know fucking dermatology shit. Fuck that. But we did things that we didn't need to do, but we didn't miss anything, so that's quite good. But importantly, we did nothing that's absolutely harmful, so this is fine. And yes, our disposition was quite good. Yeah, okay, another good result. Also, this is the ultrasound one. Also, this is a US, so admission means more charges. Yeah, this is true. This is definitely true. CME? What the fuck is CME? Oh, yeah. I can get medical credits for doing this as well. Which I think was quite good. Patient AI was once again fantastic. Yeah, no notes on that one. This is fun. I'm really liking this. I'm a bit out of my depth because, like I say, I focus on my work is emergency medicine, so I do get the luxury of going, they're not dead, so therefore I'm not paid enough to have to think about it. Also, my Google search history now thinks I have herpes, so that's cool. But yeah, so I'm a little bit out of my depth with some things, but I'm really enjoying this actually. Okay, let's go for another random case. Let's see what it is we are working with. Okay, so we have oh god, okay, this is gonna be serious then. So 21-year-old male with gunshot wound to the neck, currently breathing independently and able to speak, heart rate of 140, blood pressure of 100 systolic, SAT of 99%, pain and swelling to the right side of the neck, bleeding is controlled with pressure, C-collar not placed due to direct pressure being held, denies other pain or injury. Okay. Oh, beans. Let's see what kind of ads you get in the next few days. Yeah, that's going to be wild, isn't it? The triage nurse says this is a 21-year-old male with a gunshot wound to the neck, no obvious neurological deficit, talking, heart rate of 135, blood pressure is shitty, and we are direct to resus. Okay, so first thing we are going to do... Do you know what? Because I don't know what I'm doing, this is... I know what I'm doing, but because I don't know this interface, this is actually going to be quite good, because this is our first resus. So let's do this as a walkthrough. So this patient is in the emergency department due to a gunshot wound to the neck sustained during an altercation. Key considerations including assessing airway, breathing, circulation, disability, and exposure and exam. Yep, that's fine. Oh, okay. Is that as much as it tells us? Okay, that's literally as much as it tells us. Alright, okay, here we go. So first thing I want to do, ideally the crew would have already done this one. Let's go ahead and get monitors on us. So yeah, monitor and IV. We want that IV access to give medications. Okay, so ideally this would be happening by the nurses. We would do an airway examination. So the airway is no obstruction. Breathing exam is breathing fast, but we do have symmetric breath sounds with normal rise and fall of the chest on both sides. We've got good radial pulses and normal cap refill, which is quite good. Disability, our GCS is 15. And we've got no head trauma, which we can tell by pupils are equal and reactive. Okay, fine. Patient fully undressed. There is no obvious deformities to the chest wall, abdomen, pelvis, or extremities, so we're not looking at any other injuries here. Where did my interface go? Oh, okay. Fine. So hang on. All right, let's go this one. Patient account. So run away from him. So this is the handover. 21-year-old male presenting to the emergency medical services with a gunshot wound to the neck. Was involved in an altercation. Stranger pulled out a gun and started to run away. Several gunshots. Severe sharp pain in the right side of his neck. Shooter fled the scene, but patient was able to call 911. Persistent pain at the site of wound. No vomiting, no hematemesis, focal numbness or weakness, no chest pain or abdominal pain. Fine. Okay, that pulse rate is coming right up, which is not good. So we've already done our primary survey. So in this urgent situation, ensure the patient airway is secure by performing an airway exam and positioning for intubation. Administer sedation and paralytics for intubation to maximize the first success. Perform a... Okay. Yeah, okay, our sats are starting to come down quite a bit, so... Yeah. Initially, our sats were quite good, so I wouldn't have gone for this. Yeah. Okay, so intubation. We're going to position for intubation, which we have now done. Intubation drugs. Oh, Jesus Christ. I do not know which one we want. I assume this means we've failed. Oh, okay. Yeah, fine. They lost their neck due to this one. Early intubation is indicated for this one. Okay, right, fine. We know a bit more about what we're doing now, so this is fine. Part of my problem, I am definitely not fucking intubation trained. So I do not know what medication you give for intubation. In my line of work, intubation is only done effectively when they are already unconscious. I don't think I've ever seen a case where intubation's had to be done on somebody while they're like awake and breathing. Fine. So yeah, this is all pretty similar. So let's go ahead and do our primary survey. So the airway exam, the breathing exam, circulation, disability. There we go. So we know we've got no other wound. We're basically right back where we were before. Let's get the monitor and an IV on. And we are going to position for intubation, which we have now done. See, the oxygen saturations are fine. Yeah, so fine. Intubation drugs. Fuck. I think it's annoying because there's no way to pause this, so I don't know. So we have to give a paralytic and maintain proper Okay. We don't know where the bullet is, but airway is the kind of primary concern at the moment. So prepare the ET tube. Always give me specific situations for this one. So this is a situation where I'm basically doing things that I have never done before. So we're going to prepare the ET tube, which we have now done. And we're going to prepare the suction. So we're going to pre-oxygenate for intubation. I want to give... Okay, hang on a minute. What do we need to do here is the thing. So we're prepared for intubation. So ketamine bolus for... So I was going to go for lidocaine. Yeah, no, I'm quite happy with ketamine. So we're going to go for a ketamine bolus, which is now administered. And let's now perform the intubation. Okay, so we are intubated and on the vent. This is going to help us. Administer for early intubation to maximize. Okay, so we have to give another bolus. So this is the paralytic. Okay, our blood pressure has now become dog shit. That's probably a result of the ketamine. I imagine we are unconscious now. No, we're still conscious. Okay, I think we've missed something. Oh, blood bank, yeah, okay. So we have to transfuse some bloods. Because our blood pressure is absolute dog shit, so yeah, that does make sense. Fine, so that is going to come up. I don't actually know what this one. And a central venous catheter. Yeah, so the thing is, when you have quite a lot of blood loss, your peripheral veins can start to collapse. So this venous access might not work. So what we're going to do then is we're going to give a second IV and central venous catheter, which is basically, yeah, grim. Intraosseous line is quite good. That's something that goes into the bone. So critical actions are complete. So yeah, we are definitely ready to proceed. So now that the patient is stable, we should perform a more thorough exam. Yep, that's pretty much true. So head exam is done. So our eyes are equal, round, responsive to light. We're missing an A in there, which is accommodating. Oropharynx is intubated, which is fine. NCAT, fine. Neck exam. Swelling to the right neck side of the neck with palpable crepitus. Okay, that's quite interesting. So crepitus is basically when you get this little kind of like, if you imagine if you put Rice Krispies in a bag. That's kind of like you've got this like snap, crackle, and pop feel to it, and is usually the presence of air underneath the skin in a place that it shouldn't be. Let's do a cardiovascular exam. So we are tachy. Pulmonary exam. Clear to auscultation, this is fine. Abdominal exam. Okay. Fine, I don't really care about the rest of these. They are absolutely fine. Oh, okay. No, apparently it does want the rest of them. So yeah, basically, when you have any trauma situation, oh, hang on a minute. When you have a trauma situation, you do want to do like a full assessment. I thought this was covered at expose and undress, but no. So we've got a puncture wound to the right buttock with mild oozing of blood. It is a 1 centimeter wound with rounded edges in the mid-lateral buttock with mid-oozing. Okay. Anything at the back? That one's fine. That's fine. Skin. Diaphoretic, so we're sweating. And we've got, yeah, puncture wound to the posterior neck. Oozing of blood. Okay, so no catastrophic bleeding, which is quite good, or at least not with pressure anyway. And we are intubated, so yeah, we're pretty unconscious. I'm not happy this blood pressure is not coming up at all. So I wonder if we get him up to the OR. So yeah, X-ray chest is quite good as a suggestion. I wouldn't have done an X-ray chest. I suppose our hospitals are equipped with, like, the resus rooms either have CT scanners or have immediate access to CT scanners. So I would probably get him... I wouldn't do a chest X-ray. I would probably if this was my patient and I was in the resus room, I would probably take him straight to the CT scanner for a head-to-toe CT scan. But that isn't an option in this one for some reason. Fine, so we have the placement. So the endotracheal tube is in a good position. So we can see the ET tube here coming down. Right before the bronchi kind of branches off. So this is fine. Blood pressure is still dog shit, but that's absolutely fine. So we've done this one. What does it want us to do next? It doesn't know what it wants us to do next. So yeah, we could, actually, pelvis x-ray because we have a gunshot to the buttock. Actually, if we go to the investigate. Okay, let's go to imaging. Can we do, Okay, I would maybe try and do like an x-ray higher up in order to see if there's any bullet fragments stuck in the neck. That's, oh yeah, okay, so pelvis. There is no fracture to the pelvis, no bullet fragments. So we are quite happy with this one. We've done everything from the secondary survey. This is fine. I think this is still our... Oh. Ugh. Fuck. So consider including penetrating neck injury in your differential diagnosis. Duh. Yep. Fine. So it says, have I got... Oh, I can do all this from this one. Fast ultrasound would probably be, you know, if we had any sign that there might be anything in the chest cavity, that might be quite good. Fast scan, as I understand, it's like an ultrasound looking for organ damage within the chest and abdomen. Okay, so differential, we're going to look for trauma. So we're going to say penetrating neck injury, and do we have a laceration? Splenic laceration? No. So yeah, we don't seem to have any option for a laceration. Like just an arbitrary laceration. Can I do laceration? Yeah, no, okay, fine. Fine, so it only gives us organ damage, it doesn't give us anything for this one. Fine, so that's our differential done. Pretty obvious differential. Necessitating... Well, we know we've not got a hemothorax because we've already checked for that one, but do you know what? It wants to put it in. So a pneumothorax is the one that people have heard of quite often. Oh, this is American, isn't it? Fuck. Pneumothorax. Pneumothorax is the one most people have heard of, and that's where air gets into the pleural cavity and kind of compresses the lung. It can't expand fully. People sometimes say that your pleural cavity is a negative pressure space. That doesn't really make very much sense. It has less pressure inside the pleural cavity than the outside air. So basically when air gets into the pleural cavity, it means your lungs can't inflate fully. Hemothorax is basically the same end result, but it's caused by blood within the pleural cavity rather than air. Can we get a tension hemothorax? Get a tension pneumothorax. Fine. Oh, well. There we go. Tension pneumothorax, there it is. I don't think I actually added it though. No, I searched for it, but I forgot to actually add it. Yeah, there we go. Yep, so there we go. So, other differential diagnoses. So, let's see what we've got. So, hemothoracis. So other things that I would probably want to consider, potentially, tracheal rupture. Good choice, yep. Because any neck injury. Let's see, pulmonary contusion. I don't think that's going to be anything. Pelvic fracture, neck hematoma. Yep, also a good choice. Flail chest, probably not. Esophageal rupture is potentially an option. So your airway. So basically, we know that the bullet is kind of in the back side of the neck here. So in your neck, your airway sits right at the front, and behind that sits your esophagus. So you know, if given the injuries at the back of the neck, if we're worried about the trachea, we're also worried about the esophagus. So this is fine. Let's see what other things that we want. So the other thing that we want is pneumothorax. Oh, a poor choice. Well, not really, because if you're considering a tension pneumothorax, then you're also considering a pneumothorax. Like, yeah, I would disagree with that one. I think we're still. Oh no, we're missing one. Yeah, okay. So I think at this point, what else does it want us to do to the next phase? So investigations. So this is where we do the resus bloods that I was talking about before. So on lab work, we're going to get. I would still give an ABG, just because when you're in respiratory distress, we don't know how much the pressure on the neck. We don't know how long it was causing issues before ambulance intervention. So it's gonna shout at me. I know it is, but I still want an ABG. What was the other things that we probably want? I definitely want a coagulation panel, blood type and screen, so we can give more specific blood. Creatine. Oh no, a Chem 7, blood type and screen, and a CBC. Yeah, fine. That's all kind of what I was thinking. Oh. Yeah, I want coag as well. So we'll get these ones done. Fine. So I was right to do the ABG because we are retaining sorry, we've got too little carbon dioxide in the blood. So, you know, quite when you think of the lungs, you think that the lungs are far about getting oxygen into your body. That is definitely a very, very important aspect of what the lungs do. But also you need to consider that what does your body produce when it uses the oxygen? It produces carbon dioxide, and you need to expel that carbon dioxide from your body. If the carbon dioxide builds up, that quite often can kill you. When you think of asphyxiation incidents, you know, quite often it's like, think of a submarine that hasn't imploded but is sitting underwater with no oxygen. it's the buildup of carbon dioxide that will kill you first, and because as you breathe out, you are going to have, you know, more carbon dioxide kind of going into the air, which means more, you know, carbon dioxide that comes in. Your body's not going to be able to clear the carbon dioxide as effectively, which then causes the breakdown of your, you know, your body. And that's kind of, so we're seeing an underfunction of the respiratory system here. Bicarb, I can't remember what that one means. Hemoglobin is dog shit, so that's pretty low. Hemocrit is pretty low, and white blood cell count is very, very high. So the body is in a lot of distress here. So we need to bear that one in mind. Our bag of fluids is continuing to go down. So we have done our lab work here. A recommended action remains here. Oh, wait, one recommended action? Oh, ethanol level, yeah. Yeah, actually, that's quite a good one. We were at a bar, yeah. Actually, I missed that one from my thinking. That is definitely a good one to consider. Ethanol level. So let's do that one. See if we've got any blood in our system. We don't have any blood in our system, so this is fine. So we can move on to the next phase, which is going to be yeeting him somewhere else. If it'll let me. Ketamine infusion and a propofol infusion for post-intubation sedation to ensure ongoing sedation and comfort for the patient. Fine. So we can do an intervention, and that is going to be, we'll do a propofol intervention. Propofol is kind of one of the more common ones that we use here in the UK. So we've done that one. That whole thing you said about CO2 wouldn't affect the oxygen saturation that we see in the monitor. No, because your body can still have good oxygenation and have too much carbon dioxide. That is that's why when you look at an ABG, that's why oxygenation and carbon dioxide are given as separate measurements, because you can have good oxygen and your body still getting absolutely fucked by CO2. A good, very simple way to thinking about this is, you know, if you've ever been unfortunate enough to have like a panic attack or an anxiety attack, which is your hyperventilation, in those patients, you will see patients who have fantastic oxygenation, like 100% oxygen, but yet they're in pain. Oh, fuck. Jesus Christ. Rallic scared the shit out of me. Hi, Rallic. How you doing? Thank you so much for the raid. Thank you so much for the raid. Just to... Oh, yeah, it's because I clicked off it. Just to finish the point, Mono. So when you have a panic attack, what tends to happen is like you start hyperventilating, so you're breathing really, really quickly. And what happens is, you know, you're breathing a lot, so you're getting a shit ton of oxygen in, but your body doesn't have the time to do the full transfer to get the carbon dioxide out of your body. So yes, you've got a shit ton of oxygen, but you also have a shit ton of carbon dioxide in your body, and that results in your muscles starting to cramp up. So when you have a panic attack and you start hyperventilating, you start feeling dizzy, you start cramping and tensing, you start getting chest pains, and that is because of the presence of carbon dioxide in your blood. So that's a great example of how you can have a lot of oxygen, but the carbon dioxide is still fucking you up. Rallic, how was your burger delivery simulator? Hibble lessons, yeah. We're back with. It's been a long time since Hibble's health advice, but we're back with Hibble's health advice. Oh, hang on a minute. I'm in the wrong fucking screen. Give me 1 second. Ladies and gentlemen, we checked in on Rallic just a little bit before stream. Relic was playing some Like a Dragon and was delivering... Was it burgers or was it pizzas? I thought it was burgers. It was so random, the minigame, but a lot of fun. It did look a lot of fun. Welcome in, Cecilia. Welcome in, Ralic's Raiders. I hope you had a good stream. Relic is a good friend of mine, so, you know, if you... Burgers, pizzas, and sushi, yeah. Like I said to you on your stream, I would never have guessed that this was like a Yakuza spin-off game. It just seems so random. But yes, ladies and gentlemen, Ralic's a good friend of mine, so please chase down that Twitch link and give him a follow. And I think most of y'all from Ralic's stream probably have seen me at one point or another, but if not, hello. I'm Hibblejaybob. Yesterday we were killing things, and today we're saving things, so I'm a variety streamer. If you like a lot of variety and discussion, then, you know, feel free to drop me a follow. Where were we? Oh, yeah. So we took a pause from our patient case to chat about the dangers of carbon dioxide in your blood. So our gunshot victim is all fucky. I've actually completely forgotten where we were gonna be. What was our recommendation stuff? Tetanus. Imagine getting shot and getting fucking tetanus. Yeah, okay, so let's go to interventions, and let's give him a fucking tetanus shot. Tranexamic acid might not be a bad shout as well, given that we are yeah, because we are a hemorrhagic patient. So tranexamic acid is a medication that you can give that kind of helps to stop bleeding. So let's give that one, and that was the other recommendation that we didn't do. So yeah, that's pretty good. Because remember, we haven't done any definitive treatment on this neck gunshot wound. We're still keeping manual pressure on this to stop him from depositing his jam onto the floor. And a lemonade stand. Jesus Christ, Relic, this sounds wild. Yeah, okay, so let's have a chat with the trauma team. Down immediately to see the airway sounds. Definitive airway management. What? What? Stabilize. We've done oxygenation. His fucking what? Ah, Jesus. Did you have any grapes? I'm confused. So the airway line is pretty fucking secure. Pass. Okay, let's deal with vascular as well. So in reality, they would probably be already with you. Do you have any concern for airway compromise? No, not really. We've done this one. Penetrating. I feel like something hasn't clicked right, so I feel like we may have missed something with the airway, but like I said, I don't know intubation, so decompensation. Yeah. Okay, let's hand off. Let's hand off to the surgical team. So we're gonna prep for the operating room with a penetrating neck injury. Can I only pick one? Okay, I can only pick one, so that's fine. We're gonna hand off with this one. Finish. Oh, okay. We didn't miss anything. They were just curious. The AI tutor was okay on this one. Make it easier to find the right actions. There we go. That's kind of thing for me. Okay, so that was our first like big trauma case. You don't have any duck emotes. Sorry, you failed us. You got a penguin one. Is it a penguin? It looks like a penguin. No, it's a puffin. It's a puffin. Alright, let's go to our next case, and let's do a random case. Oh, okay. Jesus Christ. So, this is a 44-year-old male who has come in by ambulance with a cough, fever, and the trots. The patient is noted to be ill-appearing. Awake, alert, neuro intact, blood pressure is fine, heart rate is elevated, respirate is elevated, saturations are dog shit, and we have a nasal cannula with oxygen stable during transport. So we've got cough, fever, diarrhea, awake, alert, multiple sick contacts in the community, is febrile and hypoxic, so he has a high temperature and low blood oxygen, and we are direct to the isolation room. Stop coughing in my direction, you fucking fuck. Can I walk around? Can I just not be near him? They're coughing in my fucking face. Hey, Kerbaloid, how's it going? Can we, actually, that's a good shout. Can we actually give him a face mask? Procedures. Lower the head of the bed so he's pointing upwards, yeah. Oh, don PPE. There we go. Yes. We can give him a face mask. Oh no, this is me, I assume. Yeah, okay, there we go. So, don PPE. There we go. Perfect. Great. Okay, so we're gonna start first of all with well, we're already in the isolation room, so I don't think we can double isolate him. I'll tell you what, if he keeps coughing in my direction, I might just like clean his bowel out as punishment. He's still coughing in my way. Jesus. Right, okay, let's get him on the monitors to start with. So stabilize. Let's go for monitor. Start chest compressions. Okay. Oh, okay, our blood pressure is fucky wucky. Okay, before we chat to him, we are going to go straight on with the nasal cannula oxygen. And let's see if this improves things. So right now, the first thing that is jumping out in my mind is that we're potentially looking a bit septic here. We've got a raised temperature, reduced saturations, low but not critically low blood pressure, and a heart rate of 123. The respirates come right down with oxygen, which is quite good. Alright, fine. Let's talk. So it's James Garcia. Thank you for seeing me today. Jesus Christ. Ah, jeez. How long have you been feeling ill for? Excuse me, sir. We'll be performing a colonoscopy to deal with your cough. So actually, Izasia, there is a there's a great medical thing that I am aware of. I'll see if I can find the article actually, because this'll stop as soon as I come off this one. So there's a condition you have that's called AF, atrial fibrillation, and it's basically when the top part of your heart starts kind of like, you know, like bouncing around and not beating like it's supposed to. It's not as serious as VF, which is ventricular fibrillation. The way to think about it is your atria is the part of the heart that fills the heart with blood, and the ventricles are the part of the heart that like pump the blood around the body. So you can survive with atrial fibrillation, and it's a very common condition in elderly people. You can get it when you're younger, particularly when you have been acutely unwell for a few days. But on the subject of colonoscopies, there is a great medical thing. So instantly converting AF to sinus rhythm. Is this the one? I think this is the one. Yep, here we go. So this is a real medical publication. Instantly converting atrial fibrillation into sinus rhythm by digital rectal exam. Somebody fixed a man's heart by jamming a finger up there. This is honestly one of my favorite stories. And the thing is, if you look down to the cited section, there is more of these. Yeah, there you go. This paper is this thing is fantastic. Cardio version a la carte. Your choice of the unconventional. I think was it these ones? No, there was. I was pretty sure there was more funny ones here. Yeah. Jesus Christ. Anyway, one of my favorite medical stories. Okay, so he's been sick for a couple of days now. Yep, that's fine. Have you been in contact with people who are ill? Your family has been sick with similar stuff. Have they been diagnosed or treated with any illnesses? I don't know if they've seen a doctor or not. Okay, fair enough. Who knew that anal sex would be good for your heart rhythm? Well, you know. He's been coughing for an age. Yeah, he's been coughing for 2 days. His lungs probably he's probably got some of that hot spicy lung butter coming up. You don't know if they've seen a doctor or not. Okay, so fine. We can't use the cheat of doing this one. Fine. Have you taken any medications for your condition? You haven't taken anything. Are you in any pain? Some chest pain and ache. So between the fever and the ache, okay, fine. Can I give you something for the pain? So paracetamol, you're not. No. Can I give you pain relief? He didn't understand the question. Remember, this is something to look out for in your clinical skills. Positive. You need positive consent. Positive informed consent. If they show you any skills, if they show you any signs that they haven't understood what you're saying, say it in a different way, or find out where the communication barrier is, and then do that one. You don't know if it's a good idea. It will help you, it will help make you feel better and reduce your fever. I would like to give you acetaminophen. Okay, fine. So that is positive informed consent. So we are going to give him some acetaminophen, which we know as paracetamol. And this is a low-grade analgesic that is taken orally, but it's also reduces temperature. So medication response is instantaneous. Mono, I have found the answer to that one. It does seem pretty instantaneous, and as you can see, it has reduced the temperature down. So we've given oxygenation, we have reduced the temperature. Our blood pressure is still a little bit dog shit, and we're still tachycardic. So let's continue on with our things. So no obstruction or stridor, so this is fine. No respiratory distress, which we were in respiratory distress when we started, but it seems that we're not now. Fine. Slightly delayed capillary refill. So this tells me that the body is starting to, it's not delivering oxygenated blood as well as it should be. So we've got mild oropharyngeal erythema. So we've kind of got redness in the oropharynx, which is hard to point out with a fucking headset on. With limbic conjunctival redness. No, so it's not likely to be tonsillitis. Atraumatic. Eyes are pearl, and that's fine. Neck exam. Fine, so no neck pain, full range of motion in the neck. We are tachycardic with a regular rhythm, no murmurs, rubs, or gallops. In a pulmonary exam, we are tachypneic with faint rales present in both lower lungs. Now I forget the translation of these. I think that's rales is crackle. Yeah, it's crackles. It's fine crackles, whereas rhonchi is coarse crackles. So that's kind of the presence of like infection-related fluid in the lungs. I tend to just use the word crackles. I can never remember which way around rales and rhonchi are. So, fine. Remember, this could still be a poly infection, so let's just do the full thing. So there's nothing of note in the abdominal section. Can you show his full ECG? I could do, yeah. Fine, no genitourinary concerns. Fine. Have a little check of his skin, warm and dry, no rashes. Fine. Okay. Neuro and psych, I don't really have very much concern with. We've got our oxygen on. Do we have one for it's just infection? I suppose we do. COVID, yeah. Oh, COVID is a potential option. Rabies, Jesus Christ. Sepsis is kind of what I'm thinking at the moment. Could be viral, could be an upper respiratory tract infection. That was the one that we did the thing for before, tinnitus. Tetanus. Sorry, my English is hard today. Yeah, tetanus. I quite enjoyed that because I wouldn't have like thought like a tetanus injection for a gunshot wound, but yeah, I guess it makes sense. Rotavirus. I don't think there's anything else. Okay, I don't know if there's anything else I want to consider at the moment. Okay, so we seem our numbers are pretty stable with a fairly high news score at the minute. Do you need some chest x-ray? We absolutely do, Isacia. We absolutely do need a chest x-ray. As bedside tests, let's, well, you wanted to see the full ECG, so let's do an ECG. I'll probably get marked down for this, but let's do it nonetheless. Oh, that is blurry as fuck. So we are tachycardic. There is P waves, there is T waves, there is no ST elevation. We are tachy with no, like, well, actually, P waves seem to be missing from there, but there is no signs that the P wave is particularly too long, no signs that the QT interval is too long, no signs that the QRS complex is too wide. So yeah, we're tachycardic, but we knew that without the ECG, so that's fine. And we are, as you say, going to do a chest x-ray. Let's see what the damage is to the lung. So yeah, superimposed pulmonary edema is suspected. So yeah. Left lower lobe. Bilateral infiltrates. Most prominent in the left lower lobe. Pulmonary edema is suspected. Do we actually have a thing for, I hate using the American spelling for this. Okay, let's put down our pulmonary edemas. Fucking American spellings. Okay, and let's do a COVID test, huh? See what it is we're working with. Hey, we're positive for COVID. Look at that. Okay, fine. Let's before we do our other investigations, let's have a little chat with the patient again, because we forgot to do one thing. Or actually, did we forget to do one thing? No, I think it was a previous, or was it this patient? I maybe forgot to ask if he had any allergies. All right, here we go. Do you have any allergies? Watch him say acetaminophen. Fine. I was sure it said NKDA, but I now might be doubting himself. ECG is totally fine. Yep, we already covered that one. No, don't have any. Do you have any health conditions? High blood pressure and diabetes. Okay. Do you take any... Oh, actually, hang on. Type 1 or type 2? Type 2 diabetes, that's fine. Any regular medications? His X-ray looks to have both sides pneumonia. So Kerboid, when I read out what it is, that's me saying what it is. So the findings of the X-ray is says on the bottom, bilateral infiltrates, superimposed pulmonary edema is suspected. Lisinopril, HCTZ, and metformin. Metformin, fine. Okay, let's have a little look at what else we can do for him. So I want to do some blood work on him. I also want to do a, let's do a finger stick blood sugar. Fuck it, let's do a peak flow for the shits and gigs. Okay. Peak flow is something that you would more do with asthma patients, but I just wanted to do it anyway. And our blood sugar is 4, which is fine. Give him a hot water bottle. No, because he's got a fever, Isacia. He's got a fucking fever. Okay, our blood oxygen level was reduced, so I want to do an ABG to make sure there's no lingering damage or lingering presence of carbon dioxide. We'll do a chemistry. I don't care about blood type and screen. We will do a CBC. I don't think I really care about the rest of this. So let's perform these. So yes, all this comes back as fine with the exception of white blood cell counts, which are low. So we are pretty low. In terms of other lab work, we want to give... That's not the one I'm thinking of. We're going to do a... Well, we've done the COVID test, so that's fine. We're going to do a CRP. No, it's right at the bottom. So I was like, I can't find it. Get myself confused. So CRP. I don't think I necessarily want to do anything else. Okay, so CRP is fine. So we're not great. We're not terrible. We probably want to have a little think about, some antibiotics, isn't it? See, this is where I'm probably going to get tripped up a little bit, because in the UK we wouldn't really give anything for COVID except for oxygenation, which is kind of what we're doing. So, but I suspect it's going to want me to do something with them. So let's speak to respiratory. Where the fuck is respiratory? Cardiology, endo, gastro, hemonco, pulmonology. Okay, right. Jesus Christ. Avoid using non-invasive. If you think this is COVID-19, avoid using positive pressure ventilation if possible. In a negative pressure room. Jesus Christ. I mean, to be fair, we do not need positive... Yeah. We don't really need anything acute for this one. Something for fever, I'm guessing. So we've already done that, Isacia. We're a good few steps ahead of you there. Oh, your quote's coming in grand, yeah. What do you want to check? Herbaloid? His calcitamine levels? I don't think there is anything for calcitamine. No, I can check calcium. I'm pretty sure I can check calcium. Yeah, but from an English point of view, nah, yeah, I was gonna say it doesn't look like any of that's what you were referring to. Okay, so my primary concern here is so we have COVID, which would be just kind of like wait and monitor. We were struggling, okay? So our news score is pretty high. So when we came in, we were resping at 30, which is going to be 3. Our sats were fucking 90, which is probably going to be another 3. Our blood pressure is, I would probably put that at 2, and the heart rate... Yeah, our news score is really fucking high, actually. I think it's going to be like, what, fucking 14 or something? Jesus. Like, every single metric was, it was and or still is pretty fucky wucky. Fine. However, with my... So from a UK point of view, he is still stable enough to get admitted for observation without doing anything more. I know that so pulmonology says avoid using positive pressure ventilation if possible because it does aerosolization, but we're not actually doing any positive pressure ventilations. We do have a nasal cannula in for oxygen, which is working fantastically, but yeah, we don't have a need for IPPV or NIPPV, so that's fine. Can we speak to them again? Okay, you don't give us anything new. Let's try speaking to infectious diseases. Let's see what they have to say about it. So viral testing has been done. Oh, actually, is there another kind of viral testing that we can do? I wonder. What's a pro-BNT? Volume overload, no. Trying to see if there's any other parts of viral testing. Like, I don't know blood tests. So, oh, tissue oxygenation and perfusion. Actually, lactate is probably going to be a good one to do. Purely because we do have a slight delay to our peripheral cap refill with reduced oxygenation. Initially, not anymore. So let's do that and see what we're dealing with. Yeah, okay, fine. Perform. Oh, so our lactate, yeah, okay, our lactate is a bit fucky wucky, so that's fine. Let's see if there's any other lab tests that we can do. Yeah, that's literally exactly what you just said. The first time, Kerbaloid. Hang on, I forgot where I was. Right, so, no, it's not that one. Is it? So this is for bacteria, and it's viral. Fuck, I can't talk. Virology that we kind of need to do. Cell count, protein, ethanol level. Yeah, fuck it, let's do that one. Practice the hydrogenase. Yeah, that's definitely not gonna be it. Ooh, osmolality. Fine, aspirin, TSH. Thyroid function, uric acid. Yeah. Oh, no definition provided for ESR. Okay, fine. Let's do this one. We'll rule out influenza, yeah, which we've done. So it's definitely COVID. We're definitely fucky wucky, but not significantly so. I think we're gonna hand we're gonna hand over to isolation with yeah, okay, hand off. Aha. Oh, okay. So I would have said we were septic. But yeah, fair enough. All right, let's see what we missed then. So this is one of those situations that we explained at the start of the stream, which is, you know, this is hospital level medicine, and that is not what I do. So yeah, so we did the critical ones, we did the recommended ones, we didn't miss anything, so this is good. The stabilization is something that we missed. We missed two things apparently, or we missed one. Okay, so this is going to be one of the things that we talked about during the yeah, this is going to be one of the things that we talked about during the ambulance life stream. So why didn't I insert an IV? Well, because there's no, you know, I didn't give any intravenous medication, so there's no need to give an IV. And again, according to the healthcare system that we use, there is, you know, our systolic blood pressure was above 90, so there's no indication for a saline bolus. But it seems that, you know, the American healthcare system's a bit liberal with the fluids that it gives. Quite a tricky case. Yeah, you can... Told you need fluids. No, you didn't. Yeah, at no point did you say he needs fluids. Oh, right. Oh, no, hang on. You said it, like, literally 1 minute ago. Well, no. So, was it not you and me that had this conversation before, Kerbaloid? Where it's like, yeah, you know, in the UK, you know, you're not really indicated to give fluids with a systolic blood pressure above 90. So, operating within the guidelines of what we do. So investigations was fine. We did do an antipyrectic, which was quite good. We did get PPE, that was quite good. Place the patient on isolation precautions. Well, we did do that. I think there must have been a second version of this that I must have missed. And Redemsevere. Okay, I don't know that medicine, but that would make sense. And dexamethasone. Okay. Yeah, I wouldn't have given dexamethasone. In the UK, we give that for Krupp, and he had COVID, so, you know. Antiemetic, patient is nauseous. Yeah, that's fair. That's fair. So we missed quite a few things, actually. Done. Patient AI was pretty good. It's an international ways of treatment. Dex is for activating his immune system. Yeah, like I said, Kerbaloid, like here in the UK, we give it for Krupp. Yeah, so there you go. There's me getting, you know, screwed over by the differing healthcares of different countries. Okay, so we've got a walk-in patient, so no EMS report. We've got an 84-year-old female with chief complaint of leg pain after injury. Heart rate is 76 and irregular. Blood pressure is fine and appears well. All right. Let's see what we have got. First of all, we're just going to go straight on with the monitor. Everywhere we give it for crit, but that's not the only way that we can be used. Kerbloid, I hate to say this, but it feels like every time we have a single conversation, it always seems to turn into an argument. You know? Like, yeah, I don't know how many times... I know things are done differently other places. Yeah. Yeah. Ooh. There is no P waves, no T waves. So we might have some form of AF here. Right, okay, let's come on to the patient conversation. So this is Betsy. She's 84 years old. Has leg pain after an injury, but we don't know what the injury was. So what brings you in today? You've got these bruises all over your right legs, and your gum started bleeding when you brushed your teeth. Okay, that's interesting. When did this start? Bruising started after you bumped your legs against the table a couple days ago. Why not? It's always good to know other people's med opinions. This is true. This is true. Yeah. I guess my point is I'm not good with, like, backseaters. I don't mind the occasional kind of, like, inputs and suggestions and things, but I will always do these streams from my experiences as a clinician, and do what feels right to me. You know, if I wanted this to be like a, I guess, a chat controls the stream kind of stream, I would just like set up like an AI program for it, and yeah, hence Hibble's lessons. Yeah, so yeah, I've actually just seen the bruise. That's quite a lot. Yeah, because I know in our last stream, I think, was it you that we had a lot of back and forward with about the systolic blood pressure? Were you the person? Were you the person that was saying that you don't use naloxone? Or Narcan, rather? Because I remember there was two people that were there. I don't necessarily want... yeah, okay, yeah, fine, yes. Yeah. I don't necessarily want you to shut up, Kerbaloid. It's more just, you know, I'm not here... I am here to provide a stream for the medical system that we use in the country that I live in. I'm not here to constantly justify it at every single turn, and that's kind of what it seems like it comes to quite often. So I don't mind discussion and things, but yeah, I'm not good with backseating, Kerbaloid. I think, you know, yeah. Anyway, we have a patient. We have a patient. Bruising started after you bumped your leg against the table 2 days ago. Okay. Did you seek any medical treatment for it at the time? No, you haven't seen anyone for it. That's fine. So it wasn't an injury that required immediate treatment. Do you have any health conditions? No, you know, you haven't messed up the stream, Kerbaloid. No, not at all. Not at all. Remember, I am very fast in the banhammer. If you messed up the stream, you would have been gone long before now. Do you have any health conditions? So I need to find out if we've got any any conditions that might affect, like, bleeding disorders, bruising disorders, and things. You have atrial fibrillation, so we see atrial fibrillation and we have known atrial fibrillation. We've got hypertension, which is fine, and we've also got high cholesterol, which is fine. Okay. Bruising, so AFib, high cholesterol. This is fine. Okay. Are you in any pain? 6 out of 10 when you put weight on the leg. Okay, so this is the right leg bruising. Fine. Yeah, okay. The pain is a 6 out of 10 when you put your leg on it. Mm-hmm. Put your weight on the leg. When did the bleeding gums start? And how long... Okay. Oh. How long have you had... So we know that we bumped the table 2 days ago. Okay, so we've had the pain constantly ever since. But the brushing teeth only started last night. So that's like a 12-hour history of it. Fine. Okay. Do you have any medicine allergies? Do you take any regular medications? So, atorvastatin for the cholesterol, lisinopril for the blood pressure, and warfarin. Now that's interesting. Oh, yeah, okay. I was going to say, why are we on warfarin? But we've got AFib. Of course we're on warfarin. Okay, fine. Fine. So that's actually an anticoagulant. Yeah. Okay, fine. So we've got an anticoagulating medication. Do you know what? Did you fall when you hit the table? Okay, but no fall. So no head injury at all? No, no head injury at all. That's good. Okay, fine. Can I give you something for the pain? So we'll queue up some... You just want to know what's causing the symptoms. Okay, now here you go. That's not a clear consent. That sounds like a consent, but that is not a clear consent. So let's... Yeah, let's... So do you want... Okay, so no. So yeah, that sounded like a consent, but it was in fact not a consent. Okay, so let's do some checks. So the obvious one is the A to E. So we've got good pulse in our right leg, normal cap refill of the affected leg, so this is fine. That's fine. Neck exam's fine. Cardio, so irregularly irregular, normal rate, no murmurs, rubs, or gallops. We know about AF, so I'm not too concerned about doing a repeat ECG or anything. Clear auscultation bilaterally, no retractions. I don't think we actually need to do most of these, but still worth a bit of a shout, because we've got trauma to the leg, that much we know, but the bleeding gums is what confuses me. We've got no abnormal observations, but yeah, I still think we're worth doing the full biscuit. So we've got a large hematoma on the right anterior lower leg. An ultrasound check of her leg. I don't actually know if we can do an ultrasound of the lower leg. Let's see. Might be under bedside. We could do soft tissue. Yeah, we could do soft tissue to see if there's any kind of fluids building like underneath the skin. See what's there. So we've got a large hematoma of the right anterior lower leg. The compartments of the legs are soft. If the compartments of the leg are firm, that's called something called compartment syndrome, which is a medical emergency if you ever get it after trauma. But if the compartments are soft, that's fine. Normal range of motion without the deformity, this is fine. Skin exam is hematoma of the right leg with no open wound. Oh fuck, I clicked on that one. We didn't really need to do anything there. Don't need to give any treatments at the moment. So yeah. Let's see what the body's doing. Let's go to investigate and do oh, hang on a minute. Doppler testing, arterial pulses for the body. Okay, yeah, okay, we don't need to do this one. Yeah, okay, let's do soft tissue. I don't think. Oh yeah, here we go. Moderate fluid collection is seen in the soft tissues of the anterior lower leg, consistent with the hematoma. So it's confirmed what we already know. That's fine. Okay, let's have a little check of things here. I actually do want to see the coagulation panel, particularly with us being on warfarin. Perfusion, lactate. I think I do want to do a lactate. I'm probably gonna get shouted at for it, but and trauma. Trauma. Oh, that's pancreatic trauma. Yeah, okay, I don't care about that. Fine. Let's see. Amylase, blood cultures. Part of me thinks I might end up be doing a blood culture. It's this the thing that my focus is on is the bleeding gums. It makes me think that we're dealing with something interesting here. Aha, okay. So in terms of the coagulation panel, our fucking hell. Our prothrombin time is fucking 10 times what it should be. But lactate's fine, everything else is fine. This is probably fuck, I want to do a CRP, and something makes me feel I just want to do a blood culture. I think this prothrombin time is telling. I forget what the prothrombin time actually measures. Prothrombin time measures how quickly your blood clots. So yeah, so basically it takes fucking forever to our so it's what I thought. So basically the INR is also abnormal. And the INR oh, the INR is just the prothrombin time, but in a slightly different measurement, it seems. INR is equal to... Oh, it's some calculation. Yeah, okay, that's fine. So, yeah, basically, we are not... When we bleed, we are not stopping bleeding. So the bleeding gums might be... Because we were brushing our teeth at the time, which is a very slight trauma to the mouth. So this could just be a bit of an issue here. What is our possible differentials for hematology? I don't know. Oh, Jesus Christ. Hemophilia. Oh, actually, can we do clotting factors? Let's see if we can. Serum. No, that's a fucking pregnancy test. This is the one that is for... There is one somewhere for clotting factors. I just can't remember where it is. Or maybe we've already done it, that's why. Oh no, we have already done it. Sorry, I'm getting myself all tripped up. Right, fine, let's perform the two things here. So CRP is fine and the blood culture is in progress. Vein Doppler and check if it's okay, and then you'd say she can go home. A vein Doppler wouldn't work on so well on the lower leg, and I I know this because I've actually had a Doppler test done on the lower leg when they thought I was having a blood clot, and they were basically saying the vein network in the lower leg is so fucking messy that you cannot see the veins. You are only looking for the presence and the clots. When it comes to the upper leg, the veins and the arteries and things, they're all a lot bigger, and they're in more predictable places. You can see them a lot better. On testing, so you can do a lot more with an upper leg injury, but lower leg injury maybe not so much. Hemophilia can't be on a woman. I don't know if that's true. Sorry, I was in the middle of thinking something. So the blood culture is in progress. CRP is not, it's high end of normal, but still normal. Let's have a little chat with hematology and see what their suggestion is. She should probably stop her warfarin, and we probably need a reversal. Ooh, so we need to do a medication. Do we have any... Do we have any medications for this? That's the tetanus injection. We don't need that one. Insulin bolus. It's definitely not going to be there. Respiratory, cardiac. Oh, hang on a minute. I want to see what this one. Packed red blood cells. FFP. Ah, okay. I was curious as to what these were, because they were on the other side and they didn't have like an information thing against them. Specific clotting factor that can be administered via transfusion. Hemophilia A is a specific clotting factor that can be administered by transfusion for hemophilia B. Okay, yeah, we definitely don't need anything there. Okay, I'm actually not sure what medicine to give. So let's try and see. So interventions. So tox is vitamin K. So for clotting factors, okay, I didn't know that one. And then the other one it's suggesting is also vitamin K. Okay, fine. So basically the same medication. So an important component in the synthesis of key clotting factors reduced to reverse the effects of warfarin. So that's exactly what we needed. So we are going to perform this one, which is fine. And then I think we can hand her off actually. So discharge. Ooh. Oh, hang on a minute. Oh, now this is something. What does this get considered as? Huh. This is something interesting. What's this one? Disseminated systemic normal blood clotting system. Organ dysfunction. Yeah, okay, I think it's going to be this one then. I don't think any of them really fit. So disseminated intravascular coagulation seems about right. Now, do we do the INR in a week or in a day? Because I don't know very much about INR. What did they say? I think it's worth going to be checking it in a couple of days, actually. Okay, let's hand off. And see what we're dealing with here. Can't stop warfarin, but it's got to be dose calibrated. Oh, okay. I got that one wrong. So we got this one wrong because we missed some investigations. Oh, we did. So the lactate was unnecessary and the blood culture was unnecessary. We didn't x-ray the lower leg. Yeah. We didn't x-ray the lower leg. That's a very, very good point. We did the ultrasound on it, but we didn't actually do the x-ray. So yeah, that actually would have been prudent. We did miss that one. And what was the yeah, the patient was indeed stable. So we missed one investigation and we missed Da, 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 da. Oh. Are you sure you want to reveal the answers? Yeah, okay, we'll reveal the answers for this one. So Vitamin K, discharge home. So what was the doesn't actually tell me what the okay. Supratherapeutic INR. Okay. Alright, fine. Fine. Getting tripped up because I don't know what INR is. I just saw the thing that said irregular bleeding and I was like, yeah, that sounds about accurate. Patient AI was good, that's fine. Alright, I'm gonna go refresh my drink and we'll be back in a minute. That is one way to celebrate getting to 100. Jesus! Fuck! God damn it!
Boo-hoo. That's prison fellow.
Yeah, that's pretty good.
Deploy. Fucking deploy! Okay, we're now in the outer fringes of this tornado. We've deployed the probe, so let's yeet.
There we go, I gotta get the pieces outfit.
Lexi, we're in space!
Oh no! Oh my god! Oh my... No!
I think the physics janked out there.
We're like tossed like a skipping stone.
If you can hear me, are you able to sit up for us?
Oh goodness. Oh goodness. Billy, is that you?
You need to help us. I can't!
Where am I? Putting the right choice on you, but she's probably doing it with the right intention.
Wait, what the fuck? What the fuck is happening in this?
Well, you can train it here, good. If there's a dog that's not behaving, find everybody.
You know, for a ball guy, you shouldn't like splitting hairs.
I mean, I'm not balling, that's it. Alright,
But that's a flaw that I actually never appreciated. Oh well, I guess you guys have all paid for a very valuable lesson for me.
I'm never redeeming that again.
Oh, what is it?
We're
That's what you do when you only have one kid.
And we have to go on a journey. We're gonna have to go on quite the journey.
All right, no
Okay,
more
it's
alcohol. I'll just stick to the cigarettes.
It's like that French thing.
I might only have one lung, but
It's French vanilla.
Jesus, Isaac. What? Where the fuck are your organs?
oh, I got shot with an elephant rifle.
Yeah, that'll do it. I don't know what our options are. We're just gonna eat it. It's not good. Oh lord, it's not good. In fact, you know what? Don't die.
Come on! You gotta get up!
I love the amount of times that I can help people by setting them on fire. Alright, let's take stock of this race, huh? We're playing Formula 1, let's take stock of this race. So, Verstappen is currently in the lead, and Charles Leclerc is absolutely sniffing his pain. Oh my goodness, he is right behind him. Fuck me. Perez is leading a gang of Sainz, Norris, and Piastri. Alright, we are back. And for some reason or other, every time I take a break, it fucking resets the chat window, which is slightly frustrating. But yeah. Anyway, we are back. Let's move on to our next case. We're just shy of midnight, which means we don't get the daily case. But let's go for a random case. So the patient is a walk-in. It is a 49-year-old male with a burning SSCP of moderate severity with no SOB and no distress. I'm not familiar with that abbreviation. Okay, it's definitely not. Okay. It's definitely not that. Da, 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 da. Okay, it's definitely not that one. Oh, hang on, I've mistyped it, that's why. I cannot find what this abbreviation stands for. Hang on, let's AI it. The only medical use of SSCP is Summary of Safety and Clinical Performance. Okay, that doesn't make any sense. Do you know what? Fuck it, we're just going to find it out as we go. Alright, begin. No, wait, what? What? No, fuck off. Fuck off. Okay, I can't get rid of the attending somehow. Can we speak to the patient? Yes, we can. So apparently we've got burning chest pain. Okay, so we're gonna do our Socrates for this one. Can you tell me specifically? We're just starting this one, Kerboyd. Burning chest pain is all we know so far. Can you tell me specifically where the pain is? Chest hurts right here in the middle. So we've got central chest pain. Let's actually attach the monitor. Stats are fine, temperature's fine, blood pressure's fine, respirate's fine, heart rate's fine, fine. Chest hurts right here in the middle. Let's do a quick look at these three. So fine, bilateral sounds, that's fine. Fine. Okay. Chest hurts right here in the middle. Okay. When did the pain start? Pain started a few hours ago. Okay, so it's an acute chest pain that we think is burning. What we're doing when the pain started? You ate a spicy meal about 2 hours ago. Is this fucking heartburn? Is this honestly fucking heartburn? Are you kidding me? Okay, fine. So, yeah, okay. You've eaten a spicy meal about two hours ago. And that's roughly when the pain started. Did the pain start after that? Yeah, okay. No, actually, that wasn't the question. That wasn't the question. Once again, clear communication's important. It doesn't necessarily seem like he's fully understood the question. Have the pain before. Okay, right, fine. So that was not a clear answer, and now we have a clear answer to that question. What does the pain feel like? It's an aching pain, sometimes burning or feeling like a pressure. Okay. Fine. Does the pain radiate anywhere else? No, it doesn't radiate anywhere else. Do you have any other symptoms? No, you don't have any other symptoms. You would start from the ECG. Fair enough. I would not. No, I don't have any other symptoms. Where was I? Associated symptoms. Okay. Is the pain there constantly? Or does it come and go? Pain is there constantly. Is there anything that makes the pain better or worse? It's worse when you're lying flat. Okay. Worse when lying flat. Is it worse when you take a deep breath in? You're not sure, you haven't tried it. Can you try it? You don't know if you want to take a deep breath right now. Okay, well, fine, whatever. Fine. How bad is the pain? Let's see what he says to this. It's about a 7 out of 10. Okay, that's fine. Have you taken any medications today? Do you have any health conditions? I'm doing this one out of order, but fuck it. You have high blood pressure. Medications for that. So we take HCTZ for that, but we haven't taken it today. Fine. Do you have any medicine allergies? Gastritis with esophagus, but you'd start with making an ECG to make sure it's okay. Fine, I still would not. I don't know. He's never had any allergies to medications before. Okay, this is fine. Fine. Okay. So I don't think there's anything else I want to ask him just now. Oh, actually, no, there's one more thing I have asked. Have you ever had anything like this before? No, you've never had anything like this before? Okay. Fine. Okay, so let's do a pulmonary exam. So on auscultation, we are clear bilaterally with no retractions, no wheezes, bronchi, or rails. So to explain why I'm not starting with the ECG curbaloid, where we work, we use the A to E system. You know, airway's always your primary concern, then breathing, then cardiac, then what we call disability, so anything that's going to affect your kind of consciousness level, and then kind of anything else really. So with a pain in the chest, yes, it is central, but we still can't rule out airway involvement, or rather respiratory system involvement. So we'll do a full pulmonary investigation and it's fine. So next we'll move on to the cardiovascular exam, and it's fine. So cardiac auscultation is fine. Fine. What does the neck exam show us again? I don't think it's going to show us absolutely anything. Yeah, okay, that's fine. And with a central chest pain, you can sometimes get some abdominal disorders that can kind of radiate pain up into the chest. So it's still worth doing an abdominal assessment, although I probably wouldn't go this in depth. And it is absolutely fine. Fine. Yeah, so that's that tab done. Let's do the ECG. We'll do that one just now. So the ECG is NSR. Bit of a dog shit read though. There's a bit of travel and some of the fucking... Oh no, that's some thing from AF. See when you see like hospital things? Oh, hang on, can we... Oh, we can zoom in. Oh, that's cool. I didn't realize we could zoom in. Is there a limit to how many tests you can do? No, Isacia, you can do all of the tests, but remember that some of the tests are harmful to the patient. you know, like, you know, injecting them for a sample of their cerebrospinal fluid, that's not going to be something you're going to want to do without investigation. Okay, so on differential, do we have heartburn? Heartburn. Okay, no, we don't. Do we have esophagitis? I guess we can't rule out GERD or GERD in American. That is a good choice. Yep. Oh, this is the only esophageal condition you can get. Because I agree with you, Kerboyd. Esophagitis does sound like a good shout. Maybe gastritis. There's gastroenteritis. I'm gonna have diarrhea. I don't even think it is gastroenteritis. Okay, fine. Oh, what are you? What are you hinting at, Miss Attending Physician? Inquire about any recent changes in breathing patterns or any discomfort related to the chest in... So we've already done this. I guess, are you experiencing any breathing difficulties? Oh. Have you felt your breathing has changed since the pain started? I prefer a checklist to anything. When you can get back... What? Of course you wouldn't want the unnecessary spine. Protocols are good, but honestly, time you just lose time and go through all of them. Okay, so there's no changes to the breathing at all. Yeah, the way I generally tend to do it is that if it's like life critical, I will be very protocol based. But then if it's not life critical, I'll tend to be like very easy-ozy about what order I do things. Because ultimately, as long as it gets done, then it doesn't really matter. So we missed out on recommended actions. One of the recommendations I want to do is can I give you something for the pain? Watch him say no. What was it he said? A 7 out of 10 pain? It's a 7 out of 10 pain. Can we get you started on... The AI chat sometimes. Okay, we'll start off with a low-grade painkiller. We're probably going to work ourselves up to morphine, but let's see what this works. Let's see what this does. So let's do sedation. Let's go for acetaminophen. Fine, and we'll give that a few minutes to work and see what that does. I wonder what is our options for this one. Calcium carbonate, esomeprazole, or omeprazole. Oh, actually, hang on. Are you feeling nauseous? Are you feeling nauseous? No, not feeling nauseous. Okay, what the fuck is this one? Gastritis and ulcer disease, famotidine. For acid reflux, heartburn, yeah. I might try famotidine. So I was thinking omeprazole, but famotidine might be better. Esomeprazole. Oh, this is intravenous. Yeah, okay, no, fine. Okay, fine. Can I give you something to help with the burning sensation in your chest? How do I spell it? Famotidine. Yes, I think it will. You can give him some antacid and probably be better. Yeah, that's what we're doing. That's what we're doing, Carbolide. Okay, sounds good. Okay, let's give him some of this. And see what effect this has. So our attending is happy. We've definitely done the right thing. Okay, is there anything else I want to do? I don't necessarily massively think that there is. Okay, we'll check in on him. How are you feeling now? What score would you give it now? I rate it a 5 out of 10 now. Has the character changed? Is it still a burning pain? It's so good how, like, freehand this is. It's still a burning pain, but not as intense. I need to check the formulary. Nope. Nope, okay. I was gonna say about giving omeprazole as well, since they do have slightly different... they kind of ultimately treat the same things, but via different actions. But yeah, there you go. Combining ondansetron and famotidine may increase the risk of an irregular heart rhythm. Yeah, so yeah, we're not gonna do that one. Okay, fine. I'm curious as to what it sees is... Oh, apparently missing. Aching, burning, pressure. The pain does not radiate. Yep, differential diagnosis. Pneumothorax, pulmonary embolism. GERD we've got, and myocardial infarction. Okay. I mean, it's not... I mean, I guess it could... I guess it could technically be an N-STEMI, but this doesn't look like an N-STEMI. But let's do... So, in this one, so... Emphema. Outside the line. Nope. So it said the... Tracheobronchial foreign body. Oh, acute chest syndrome. It thought MI. I wouldn't have said he looks like an MI patient. I mean, he could literally just be an N, like, I mean, you can't rule out M-STEMI, but I don't think this is... atypical chest pain is probably not a bad shout. I guess myocarditis and pericarditis are probably good choices. We're definitely not an SVT, vasovagal syncope. Oh yeah, that's pretty fun. Okay, so we've got a lot of potentials here. I think I want to do let's do a chest X-ray. Make sure we're not missing anything in the chest. Let's see what it is that we are working with. No pneumothorax or rib fractures, normal lung fields with no evidence of edema or infiltrate. So this is fine. So this is a nice and normal chest X-ray. Fine. Do you know what? If we're thinking MI, let's go for some tests. So I'm not concerned about ABG. Let's do basic chemistry because why the fuck not? Let's do a CBC because I want to see what the fucking white blood cell count is doing. Let's do a D-dimer and a troponin T for checking what the heart is doing. And then we'll go from there. Oh, let's do other labs. Let's do a CRP. Fine. By the way, in the UK protocols, do you do defibrillator on asystole or low wave fibrillation? No, so we don't shock asystole. If it's any kind of VF, then yes, then you will shock VF, but we don't shock asystole. Okay, so CRP is not raised, troponins are not raised, the D-dimers are normal, so that tells me we're not having an MI, and it tells me this is unlikely to be an infection. And our numbers suggest this isn't an infection. I'm curious as to what I am. Reasonable diagnosis is. I kind of want to see what here. So GERD, atypical chest pain. It's not asthma. I don't think this is costochondritis. I've never heard of before, and there's no information. Yeah, okay. Reflux of gastrite into the esophagus. See, this is quite interesting because the way this is worded makes it sound like it can be acceptable to call it like a one-off, whereas for us in the UK, like typically GARD refers to like the constant recurrence of acid reflux rather than just a one-off. But this sounds like it could just be a one-off. But yeah, that's fine. That does make the most sense. Okay, fine. I'm not necessarily sure there's anything else. What other painkillers do I have? I'm loath to give him morphine. I'm really loath to give him morphine. Where the fuck is resuscitate? No, here we go. Here it is. So I could give ibuprofen. Ibuprofen does typically aggravate the stomach, though. Okay, let's have a little still burning pain, but not as intense. Okay, let's see what else the attending... Oh yeah, handover plan. Yeah, okay, that's fine. We're done. So normal ECG, normal troponin, so we've done the rest of the things, with a low heart score, negative. Yeah, fine. I'm happy with that one. It does sound pretty girdy. So discharge with primary care plan, and I think it's just GERD or GARD as we would say. Yeet. Done. Yeah. Okay. Fine. The AI tutor is still annoying. I don't... Fine. Just send this guy home. Yeah, that's what we're doing. We're definitely not sending him up into the ward for gastro, for fucking reflux. Okay, it's after midnight, which means we have unlocked the daily case. Oh. Oh. I guess this uses US times. Well, fair enough. Okay, I guess another random case. Another random case it is. So we have a walk-in patient who's a 47-year-old female with breast cancer, presents with fever, no vomiting or diarrhea, accompanied by her husband. Ooh, okay, this is interesting. Fair enough. No thanks, disable walkthrough. Yeah, I don't know why it keeps just suddenly turning on. Oh, thanks. Thanks, Nightbot, for being inappropriate again. Okay, first things first, let's have the nurse. So this feels slightly backwards, because, like, the first thing that happens in a UK hospital is the triage nurse automatically, like, does obsets, so you have them. Oh, okay. Okay, that's not great. Automatically does obs, and basically does this stuff. So this can all be done basically without, you know, but with looking. It can be done very quickly. So yeah, okay, so she's pretty alright here. So that is a low blood pressure. Saturations are a bit and the temperature is raised. That's a bit of a problem. Okay, let's just speak to our patient now. We've got nothing immediately life-threatening going on. Blood pressure is low, and I've learned my lesson from following the British healthcare system that this is acceptable in the UK, but it's probably too low for this simulator. So, Fever, thank you for seeing you today. So Anna, so. Fever. Let's just start with a very general thing. What brings you in today? You got a fever and you're not feeling very well. Okay. When did this start? When did this start? It started about 4 hours ago when you woke up to urinate. Okay. Were you feeling well before you went to bed? Not really, you felt a bit off. In what way? Dizzy? Nauseous? You felt warm and wasn't feeling very well overall. Okay. Do you feel dizzy or nauseous now? Are you in any pain at all? No, not in any pain. Oh. Oh, bless me. Okay, no breathing difficulties. This is fine. Okay. Okay. We already know something about her medical history. What is your medical history? Breast cancer, high blood pressure, and a mastectomy with radiation. Okay. Was that recent? No, it was a while ago. This is an important question. Are you under any active chemotherapy? It was 2 days ago, so we've had recent chemotherapy. Okay. So this could be neutropenic sepsis. That's something that can happen after chemotherapy. Okay. Last chemotherapy 2 days ago. Any complications from that? Been feeling less hungry So reduced appetite, reduced fluid intake. Okay, fine. So nothing abnormal from the chemotherapy itself, but that doesn't mean we're not in some kind of neutropenic sepsis. Fine. Okay. I've been feeling less hungry and less drink. Yeah, fine. Are you on any medications? Zofran is needed. You've been taking Cinepro. Oh, you haven't been taking. Okay, yeah, fine. Okay, fine. So we understand that we have low blood pressure. So this is perhaps not abnormal. So we're probably rocking with a news score of, well, the specific number would be important, but I'd probably say like 3 or 4 just now. Hey Draco, Draco, this is a website. I actually got this as an advert, on Instagram, and it looked pretty good. So I thought I would give it a bash. All right, let's on lisinopril and chemotherapy. But you haven't been taking lisinopril because of the low blood pressure. Fine. Do we have any allergies? Do you have any allergies? No, we don't have any allergies. Fine. Okay, let's continue our checks. So neck exam is probably going to be unimportant. Okay, let's do pulmonary exam. Clear auscultation, no retractions, wheezes, bronchi, or rales. Cardiovascular is regular rate and rhythm. That's fine. Abdominal exam. We're going to give her the full works. With a fever, so being on chemotherapy and having a fever, generally feeling quite unwell, we have a very low suspicion of infection. Any coughs? No coughs. Yeah, so we need to do a full assessment to try and work out where, if this is an infection, where it is. So abdomen is soft and tender, non-distended, normal active bowel sounds, no percussions, no rebound guarding, rectal examination deferred. Oofed. Fine, so there's no abnormal discharge from down there. Nothing on the back. Nothing there. Skin is fine. Neuro exam. That's fine. Yeah, okay. Fine. We are absolutely grand. Okay. Alright. I don't think we need to do anything at the moment. So, let's go to lab work. I think we're basically going to be doing this as exclusively lab work. It does annoy me that things keep moving around. This is kind of annoying. Okay, right. So as lab work, we're going to do. I'm not really that concerned about ABG, but we'll do basic chemistry. We'll do CBC. Ooh, differential. The fuck. Abnormal blood. Yeah, okay, that's fine. Okay, so what we need to try and do is we need to find the one, because there is some blood tests that you do specifically, for cancers. Phosphates. That's kidney disease. ProBNP is for heart failure. Troponin is for that one. Urinalysis. Yeah, do you know what? Actually, let's do a urinalysis. Other examinations are going to be okay, I'm not too concerned about that one. So blood culture, susceptibility. However, the results are not ready right away. Yeah, do you know what? I kind of want to do a CK. Ethanol level, I don't really care about. Liver injury. So this is all basically going to be in the bloods. Osmotility, I don't really need to do. Detect abnormal blood cells. Yeah, so this I think is going to be quite important. Serum HCG. Oh, it's a pregnancy test. Uric acid. Yeah, so this is the one that we want for cancers. I don't think I really care about the rest of them. We'll do a CRP as well. We'll do lots of blood tests because I don't know much about oncology. I do not know much about oncology. Okay, so our white blood cell count is very, very low. But our CRP is normal. So this tells me that we might not be dealing with an infection. Yeah, you still gotta exclude any infections. Yeah, so we've kind of working towards this one. So urine dip is clear. Respiratory is clear. I guess we could do a chest x-ray just to absolutely rule out there's nothing massively fucky-wucky going on with heart and lungs. I highly doubt there is going to be anything in here. Yeah, no, nothing. Nothing in that at all. So our white blood cell count is low, but that could just be the chemotherapy. With the CRP normal, I'm not jumping to thinking that there is infection going on. Okay, one thing I want to do is I want to see, is it under hemo, I wonder, or miscellaneous? No, it might be under blood bank, isn't it? So I wonder... Gee, I don't really think anything... I don't really think we need very much of this one. Barry. Yeah, okay, fine. So we can do intravenous immunoglobulin for immunodeficiency, but I'm not really too sure about how immunodeficient we are. Let's speak to oncology and see what they say. So consult hemo-oncology. Since the patient is neutropenic with a fever and lives so far from the hospital, so yeah, okay. So we are neutropenic. Wait, were we told we were neutropenic? Neutrophils. Okay, so I don't really know what these numbers necessarily mean. But our white blood cell count is fucky wucky. Okay, so let's look for hemo-oncology disorders. So blast crisis, sickle cell crisis. Ooh. Huh, the thing I was looking for isn't necessarily here. Let's try and find it. Febrile neutropenia, I guess. Let's see if there's anything else. No. Pneumococcis, no. With a new neutrophil count. Yeah, okay, fine. So this is febrile neutropenia is basically what we would call neutropenic sepsis. Can you show the x-ray again? So I think, I hate to say this, I think the x-ray is just a generic picture because I think it's been the same like the last 3 times we've done an x-ray. But at the bottom it says, normal lung fields, no evidence of edema or infiltrate. It will tell, I know for a fact it will tell you down here if there is any abnormal findings. Okay, I don't think that there's anything else. Let's just double check this one again. Hemo-oncology, blast crisis. Yeah, okay. So what other ooh. vasoactive. Has anyone here ever seen the wonderful medication that is methylene blue? It's a great medication. Let me see if I can find it. Methylene blue IV. Da, 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 da. Where is it? Where's a good one? Yes, there you go. Look at that for an IV. Yeah. Imagine going into hospital and seeing them pill that as your medicine. Sadly, that's not something that we can give here. Okay, so what we want to do, let's have a look at our analgesics. So, oh fuck. So acetaminophen, fever reducer. So it's an antipyrectic. Oh, we can't give ibuprofen anymore. That seems to be removed from this. Did you ever try karaoke streams? Absolutely not, Kervoid. Absolutely not. Okay, let's get some consent. Okay, so based on our examinations so far, we think you have febrile neutropenia. Is this? We need to admit you so the specialist can look after you. What will happen next? You'll be taken to the ward where they will look after you. I'm glad to hear that they will take care of me. Can we give you some medications to lower can we give you some medicines to lower your temperature, increase your blood pressure, or would you rather wait until the ward? I think it'd be better to get those medications in now. Okay, let's get started with the acetaminophen to bring that one down. And in terms of fluids, now I don't know very much about pressors. Yeah, we do not use pressors in the pre-hospital setting, so I am entirely out of my depth with that one. Blood bank, intravenous immunoglobulins. What I think I would want to do, I don't know where I can do it. I know it exists, but actually, fuck it. Let's use the search. Let's do saline. Okay. So I could use a presser to bring up her blood pressure. I would prefer to use saline because that's going to help with the cooling as well. You don't know why you don't like them so much. What do you mean, Kerboid? Fluid will help with her chemo intoxication. I'm literally talking like, look, we've got saline here. What are you talking about? Okay, right. Let's get an IV in. Yeah, saline is fluid. So, yeah, when I'm talking about giving her saline, that's giving her fluids. Let's get an IV line in her. She's already consented to them. And we are going to give a saline infusion rather than a saline bolus, because the salt content of 25% is quite high. Okay, let's get this one in. So this is going to help bring her blood pressure up, and it's going to, you know... Here's me thinking this was instant, but I don't know if it is going to jump up quite quickly or not. But we do have the treatment in place. Usually you don't like to give saline to patients. Yeah, it's kind of hard for me because you know, I've been in my job for a good few years, and yeah, I can't speak for hospital setting, but certainly pre-hospitally, we wouldn't give saline for a blood pressure of 96. But you and I have had that chat quite a lot. That's basically why, because you know, this effectively me giving saline to her now is just kind of Hail Marying a solution at the problem that kind of goes against our normal way of working. So that's why I'm loath to do it. Okay, let's get her up into the ward. So I think this one we're gonna go to. So we're gonna admit the patient to the oncology service. Okay. So in terms of stabilization, but don't forget to monitor her. So we did give her fluids. Wait a minute, is there 2 fluid sections? Hang on a second, can I... So we did give her fluids, but apparently the wrong one. We might have missed... So we missed something in this. What did we miss? So we missed blood cultures. I wouldn't have done a COVID test. I disagree with that one. You wouldn't be wrong to, but if they've got no respiratory condition, no respiratory symptoms at all, I wouldn't jump to doing a COVID test. But yeah, fair enough with that one. So interventions. So cefepime, I don't know what cefepime is. Don PPE. Yeah, okay, actually that's fair. And isolation precautions. Yeah, I think we're a lot more. Liberal in the UK when it comes to neutropenic sepsis, because it's just normal precautions. Yeah, okay, but that's fine. That's fine. So I don't know what cefepime is. Let's actually. Yeah, patient AI was great on this one. Patient AI is fantastic throughout this. Okay, let's go for... Yeah, okay. Well, we need to wait for it to load. So, cefepime. Cefepime. Let's read it. Cefepime is a powerful fourth generation antibiotic. It's commonly used to treat sepsis and bacteremia and hospital required. Yeah, okay, fine. I don't know what that is, so yeah, fair enough. I would have lost out to that one. And so I think, is it here? Yeah, okay, so here is the okay, fine. So I think you are wrong to do your fluid treatment through the intervention fluids. I think it has to be through the stabilization thing. So I think that's just a mistake with the interface there. But fine. Okay. So let's go back to the main menu. There's literally almost no cases where saline will do worse to a patient. Well, that's not true, Kerbaloid, and we've chatted about that one. We've chatted about that one, because if their blood pressure is too high and you give them if you give them more fluids to increase their blood pressure, you know, you increase the risk of hemorrhagic stroke. So yeah, I admit it's a small subset of patients that you will experience, but it is possible to do harm with saline. But I do admit that that for like a most normal patients without extreme blood pressure, yeah, you're fine to give saline. Okay, let's go for a random case, and I think this is gonna be the last case of the night. So, patient is brought into AD by a private ambulance. Security reports a horse-drawn carriage of some kind. The 71-year-old male presents after a slip and fall on an icy roof, query hanging up Christmas lights, head strike with a possible loss of consciousness, is currently GCS 15 and is not anticoagulated. And he's fucking Santa. Of course he is. Of course he is. Okay, let's just go ahead and get the... Yeah, I think what also confuses me is the fact that the interface is different for every patient. I think it depends what room you're in, actually, yeah. Okay, let's just do the quick ABC. Fine, so there's nothing life-critical that I need to intervene with, so let's just speak to the patient. So Chris Kringle. Chris Kringle, thank you for seeing me today. What happened? Bumped your noggin. Tell you what, actually, there is 2 more life-critical things that we need to do before we move on. So, abrasion with moderate hematoba to the occiput without laceration. No step off, we are parallel, and the oropharynx is clear. No masses, no C-spine concerns. Okay, fine. Okay. Okay. Do you remember everything that happened? Let's see if he remembers everything. I'm not sure if I lost consciousness, but I did see stars. Okay. How did you fall? Let's probe him for more details. You slipped in the ice and fell backwards. Okay, so our memory isn't really that intact, but you did see stars. Okay. Fine. And the injury was to the occiput, so we're at the back of the head. Yeah, it's to the occiput. So we've got the injury in the back of the head. Okay. How is your vision? Any blurriness? I don't know if that's how you spell blurriness. Haven't noticed any blurriness. Okay, that's fine. Any nausea or vomiting? But that's better now. Okay. Fine. Okay. Alright. Are you in any pain? Let's see what Santa says. You have a bit of head pain, but it's nothing that a hot cup of coca won't fix. How severe is this pain? Not too bad, just a bit annoying. Okay. Do you want any pain relief? Well, I can't prescribe that, but you can get it from the canteen. Okay, fine. So no pain relief. That is a refusal. So that's fine. Okay. Okay, fine. Let's do some... oh, no, hang on. Okay. Do you have any health conditions? see what the answer is to this one. Well, I could stand to lose a bit of weight, but must be all the milk and cookies. Yeah, this is definitely Santa. Okay. Do you take any medications? I do like the fact that we have Santa. And any allergies? You're allergic to reindeer dander. Yeah. Okay. Wait, do we have a sea collar on? Or is it a scarf? I can't actually see. Okay. Was that C-spine tenderness? Okay, fine. Right, let's do our checks. So, clear auscultation, cardiovascular, regular rate rhythm, no murmurs or gallops, abdominal exam. Soft non-tender, that's fine. Back exam is going to be quite important. No CVA tenderness. No tenderness to the thoracic or the lumbar spine. Musculoskeletal exam. Normal range of motion without any... That's fine. We do definitely want to do a neurological exam. Awaken alert. Clear speech. The cranial nerves 2 through 12 are intact. Normal proctol, no drift or dysmetria, so this is fine. And because he thinks he's Santa, we'll just do he's filled with good cheer. This is silly. Okay, this is fine. So, I don't need to check his. Oh, actually, he does have a lower back injury. Fuck it, let's just check that one. There we go. We've just seen Santa's penis. Okay, fine. So I think in terms of our exams, let's see. I don't really care much for a Doppler. Let's go to imaging and let's do a CT head, given we can't do an X-ray head. So let's perform this and see what our results are. CT head is normal without evidence of mass or hemorrhage, with mild occipital scalp swelling. So that is not a particular concern of ours. So basically the things that we are looking for there are a fracture to the skull or a bleed within the brain, neither of which we seem to have. We know we're not anticoagulated, so that's fine. Imaging, trying to see if there's anything else. And I think it's probably going to be worth... wait, what's the difference of this one? Okay, fine. So we're not too worried about strokes. This is fine, but I do want to do a C-spine. Okay, no damage to the C-spine at all. You know, there was once a horrific case that I read about where someone had this weird surgery to the base of their skull that left a very, very small hole between their nasopharynx and the basically their spinal column. And so one time at hospital they had to be given an NG tube. And I've seen two cases of this, actually. I've seen one where the NG tube has gone in through this gap here, and one where it has gone down the spinal column, resulting in total paralysis for the patient. And then also one where it went in and then curled upwards, and the guy had like an NG tube, a feeding tube, inside his brain, which is, crazy. Okay, fine. So CT spine is clear. I don't think we need to do any medications. Decontaminate, lower head of bed, lumbar puncture, place patient, remove... Okay, we do have a C-collar on. We can remove the C-collar, because that has been cleared. And I was right. We do have a C collar on. So I think we've gotten away with this one. Why CT not MRI? Yeah, I don't know. Would usually use CT for this. Could do. Yeah. So I guess we could do the C-spine MRI to see the nerves. I was mostly considered with the what's it called? Fucking bone. But we're not concerned about the nerves. Yeah, it's fine. It's normal. It's absolutely normal. Yeah, because we've already done a cranial nerve assessment, and yeah, there's nothing of concern in the C-spine. I guess it's the lower back, but again, I'm not really. I'm not really concerned about these. Allergic to reindeer dander. Okay. How are you feeling now? You still have some head pain. You still have head pain. Are you still declining pain relief? Or would you like some now? Let's see what he says. You're still good with a cup of hot coffee. Can I give hot? No. Okay, funnily enough. I thought because you can change the interface between things, I wonder if it'd been added. We can't give you that here, I'm afraid. I'm having a conversation with Santa. Okay, so we are still declining pain relief. This is fine. Can you move your legs? Okay. Any strange sensations or numbness? Nope, no strange sensations or numbness for me. He's fucking fine. He's fucking fine. He's fine. Is there anything else we can do for you? Yes, pain relief would help with the pain. Okay, we finally have consent for the pain relief. Finally. Jesus Christ. Give him some acetaminophen. That'll do. Let's speak with... oh, we don't even have trauma. Yeah, we don't even have trauma in this hospital. Admit Santa, Christmas is cancelled. Prep for OR. Oh yeah, shit, okay. Hang on, our differential. So we need to do a differential, which is going to be trauma. And it's going to be a closed head injury. We're not showing any sign of concussion. I guess we could put concussion down as one of the possible things. But yeah, I really don't think it is this one. So, discharge to the North Pole with bed rest. I bet you this is going to be wrong, but let's save Christmas. Yeah, we're done. Hey! So we only missed one investigation. Okay, yeah. So Thanks, Kerbaloid. The MRI that I wasn't going to do cost us the 100%. So we did the critical thing, and we did one unnecessary procedure. Yeah, that's fine. Still 98.7. That's a good one. All right, I feel kind of scammed because that was quite a fast one. So we'll do one more. We'll do one more. Let's go for another random case. Ooh. Okay. So the patient walked in. It is a 69-year-old male brought to the ED by the wife with an acute onset of confusion, slurred speech. Stroke alert. Okay. So let's be very fast with this one. And we're going to very quickly do an ABC while we get the monitor on. Okay, this is fine. So head and neck. So our eyes are pearl. Fine, that's fine. Let's do a neuro exam. So this is going to be our fast test. So somnolent. Can't cooperate with detailed neurological exam. Incomprehensible speech. Yeah, okay, fine. So I'm gonna quickly look up that word there. Somnolent? I've never seen that word before. Sleepy, drowsy. Okay, we're not gonna try and speak to the patient just now. Alright, well. Let's very quickly try and rule out any signs of injury. So cardiac exam fine, pulmonary fine, abdomen fine, back musculoskeletal and things. So we've got no injury that would explain the symptoms that we've got. One test that we need to do quite quickly is the blood sugars, because low blood sugars could produce symptoms similar to a stroke. Okay, they are very, very low. So what we're going to do then is we are going to... Martin's wife, Fran, please help him. Worried about what's happening. Does he have diabetes? So as she's answering that, we're going to insert an IV. Which we now have. Yes, he has diabetes. Insulin last week because his blood tests weren't getting... Okay, so we've just gone on to this one. So I think what we need is an intervention. And we're going to give glucose. Oh, I would give glucose. I wouldn't give glucagon. What's a D50? Oh, is this dextrose? No, this is malnourished. When used with insulin in patient with elevated... Yeah, okay, it is dextrose. No. Okay, let's give glucose. Yeah, okay. Glucagon, sorry. It's annoying there's no glucose. IV glucose is always better as a first-line treatment than glucagon. Okay, let's see what that does for us. Okay, that's better. Martin, how are you feeling? Yeah, okay, fine. So are we still symptomatic? Awaken alert, speech is clear. No drift or dysymmetry. Okay, so differential is hypoglycemia as our first, and stroke as our second. We're giving him some sugars to boost. They were critically low. Okay, let's just absolutely rule out a stroke with some imaging. So we'll do a CT. CT head and MRI head. I mean, we've already treated him. So no masses or hemorrhages. Where's my... Oh, it's here. Investigations. Yeah, okay. Alright, let's go back to the exam here. Let's just repeat our assessments. So, that's fine. This is fine. No changes in heat. Nothing there. Nothing here. I'm not going to bother repeating the abdomen. Not going to bother repeating that one. Actually, no, it might be worth doing it. Yeah, okay, fine. No CVA tenderness. The reason why I keep getting tripped up with CVA is because in British medical parlance, CVA is, you know, basically a fucking stroke. I forget what it's an exact abbreviation for. Cerebral vascular something. No clubbing, fine. So awake and alert. So we're now GCS 15. Okay, this is frustrating because we have given definitive treatment. Well, we haven't actually. Glucose is. Do you know what? Fuck it. Let's give D50. So D50 bolus is a simple sugar that will provide calories in malnutritious person. When used with insulin in dextrose allows for the uptake. Okay, we need to check potassium levels then. Let's do quick bloods, lab work. So we'll do chemistry. Where's potassium? Is potassium in other labs? Ah, okay, we don't have potassium. Does this one have potassium? Oh, yeah, this one does have potassium. Okay, yeah, that's fine. Let's do this one. Wasn't there one for... Isn't there something you use for stroke? D-dimer, is it? Yeah, okay, I do want a D-dimer. I was sure there was another blood test that you could do specifically for stroke. I really don't think we're dealing with a stroke though. Let's just perform these results. So glucose is now too high. D-dimer is 0, Jesus. Okay. Okay, let's consult with, I think it's gonna be neurosurgery. So yeah, I mean, we've already done that one. Fine, neurology then. Yeah, okay. TPA. TPA neuro, medication used to treat an acute stroke. So this is frustrating. This is frustrating because we're fast negative now that we have fixed the hypoglycemia. Oh, shit, what was our potassium? Our potassium was normal, wasn't it? Yeah, our potassium was normal. But it's still blocking me from doing, like, we have given definitive treatment. The patient is now fine. The patient is GTS 15 with a complete resumption of all... Fuck it. Do you know what? Actually, yeah, fine. All right. I guess I am not going to be able to rule out a stroke here unless. Let's see the key actions. So exam. We've done all this. We've done an IV. We've done this one. We missed a bedside test? No, because we've done all the bedside tests. So we've done everything right. Oh, the D50 bolus. Yeah, okay, fine. I wasn't sure about the D50 bolus. Again, in a patient who you have given glucagon to. So, when it comes to hypoglycemic attacks, intravenous glucose is the gold standard of kind of treatment. However, if you have to give glucagon, it's always best to have them eat something rather than then supplement it with something else. But yeah, okay, we'll give the D50 bolus. Fine. And then we're going to observe an ED and discharge. Handoff. Fine, that was a nice easy one. Communications. Oh, yeah, okay, because we accidentally called neurosurgery. Yeah, fine. I just wanted to see what their input was purely because of the fact that it wouldn't let me do a fucking MRI scan. So that was slightly annoying. The D-dimer was unnecessary. I thought it was going to be, but do you know what? That still wasn't too bad. That was another nice short one to oh, actually, hang on. So it was okay. When the patient became GCS 15 again, I still couldn't speak to him. So we fully treated him, but the wife was still like, oh, he's not going to answer. He's not going to answer. All right, well, that was actually a lot of fun. I really enjoyed, I actually really enjoyed that, to be honest. There was, yeah, there was quite a lot of stuff that I didn't know about. But yeah, still really, really enjoyable. We are going to hand you off now to someone else. And let's see who I have who is up and around. Let's see who we have. Fuck it. Let's go for a raid on Wicked Phoenix, who we raided a little while ago. Funnily enough, I think I was the only person who was streaming this game in particular on Twitch. So, funnily enough, there isn't really anyone else streaming it. So I'm going to hand you over to Wicked Phoenix RP, who is currently playing on Wild RP, doing some shenanigans over in Gawarma. Hopefully you all enjoyed the stream and the content. I actually really enjoyed this. Out of all of the medical kind of simulators that I've played, this is probably one of the best ones that I've ever experienced. There are some, shall we say, international differences. It's not strictly that I disagree with them, but it forces me to do things that, like, I would get reprimanded for if I did them, you know, in real life. Well, actually, okay, let me rephrase. Somebody who's qualified to do those things would be reprimanded for doing the things that, like you've done in this, even though that is what it's telling you to do. So, you know, kind of going outside my knowledge area quite a lot with this one, but still really enjoyed it. Hope you did too. We're going to be streaming again tomorrow with some what are we streaming tomorrow? We are streaming some IL-2. We're going to try a VR stream again. I know I did it last week and it didn't really go to plan, but I think that it is all up and working now. So I will see you at 9 o'clock tomorrow, but for just now, let's go show some love and support to Wicked Phoenix RP, and I'll see you all next time. Bye. That is one way to celebrate getting to 100. Jesus! Fuck! God damn it!
Oh, that's prison, fella.
Yeah, that's pretty good.
Come on, deploy. Fucking deploy! Okay, we're now in the outer fringes of this tornado. We've deployed the probe, so let's yeet. Oh.
There we go. I gotta get the pieces out of it.
Lexi, we're in space!
Oh no! Oh my god! Oh my... No.
I think the physics janked out there.
We're like tossed like a skipping stone.
If you can hear me, are you able to set up for us?
Oh goodness. Oh goodness. Billy, is that you?
You need to help us. I can't!
Where am I? Putting the right choice on you, but she's probably doing it with the right intention.
Wait, what the fuck? What the fuck is happening in this?
Right, but you can train a cougar to behave, but if there's a dog that's not behaving and biting everybody, you won't.
You know, for a bald guy, you sure like splitting hairs.
I mean, I'm not bald, that's weird, but, you know. Alright, whatever.
But that's a flaw that I actually never appreciated. Oh well. I guess you guys have all paid for a very valuable lesson for me.
I'm never redeeming that again.
Oh, what is
I
it?
suppose
that's what you do
we have
when
to-
you only have one kid.
And we have to go on a journey. We're gonna have to go on quite the journey.
All right, no
Okay,
more
it's like-
alcohol. I'll just stick to the cigarettes.
It's like that French thing.
I might only have one lung, but that's
French vanilla.
Jesus, Isaac.
What?
Where the fuck are your organs?
Oh, I got shot with an elephant rifle.
Yeah, that'll do it. I don't know what our options are. We're just gonna eat it. It's not good. Oh lord, it's not good. In fact, you know what? Don't die.
Come on! You gotta get up!
I love the amount of times that I can help people by setting them on fire. Alright, let's take stock of this race, huh? We're playing Formula 1, let's take stock of this race. So, Verstappen is currently in the lead, and Charles Leclerc is absolutely sniffing his cane. Oh my goodness, he is right behind him. Fuck me. Perez is leading a gang of Sainz, Norris, and Piastri.
It's like you're having the best day there, Bill.
Another day over and deeper in.
Oh fuck. Oh fuck.
Don't sneeze on me.
Nope.
That was a strong fucking sneeze.
That was a very strong sneeze. Past him, clean the fuck out. Yeah, we're just gonna gloss over that entirely. It did not work.
President.
Oh, actually. Oh my! Oh!
Boingy
I am the best at this game that there